Good morning. It is 9:03 a.m. on February 19, 2026. The board meeting of the Oregon State Board of Nursing is now called to order. A notice of this board meeting was published by Rachel Prusak, Executive Director, in accordance with the Open Meetings Law. If necessary, the board may also meet in executive session as authorized by ORS 192.660 subsection 1, ORS 192.660 subsection 2F and L, ORS 678.126, ORS 676.165, and ORS 676.175, subsection 1. Board members and staff stating that they are present are attesting to understanding the confidentiality of executive session and have taken steps to ensure that the executive session proceedings are not observed or heard by anyone not authorized by the Public Meetings Law, ORS 192.660. Is there a roll call by our secretary?
Yes. Oleniki Tolabola,
Here.
Margaret Hill,
Present.
Claire McKinley Yoder, present. Joni Callis.
Here.
Linda Stanich,
Present.
Rachel Dennis,
Here.
Felipa Nesta, Rachel Mitzel excused.
There being a quorum present, I declare this board eligible to conduct its business. Do we have a roll call by Executive Director?
We do. Good morning, Madam President, members of the board, and the public. I will do roll call, starting with our policy analysts coming over to this side of the table, and then we'll have those that are here in public just announce that they're here and who they are. So go ahead, policy analysts. Start over there.
Michelle Bell, present.
Laura Blackhurst, present.
Gretchen Cook, Policy Analyst, RNLP in Practice, present.
Lauren Rauch from DOJ, present.
Rachel Prusak, Executive Director, present.
Randy Ritter, Executive Assistant, present.
Phil Young. Sam Fontano.
John Etherington, Board Staff.
Jana Bitton, Executive Director of the Oregon Center for Nursing.
Christy Simila, Oregon Nurses Association.
Carrie Firestone, Walla Walla University.
Mary Lopez, Western University of Health Sciences.
Sarah Jacques, Western University.
Michael Marinello, Western University of Health Sciences.
Nicole Van Winkle, Board Staff.
Natalie Barron, Portland Community College, Nursing.
Janine Hull, Portland Community College.
Jason Johnson, Portland Community College.
Erin Ferris, Investigations Manager, Oregon State Board of Nursing.
Kimberly Goddard, Chief of Staff, OSBN. Thank you. So it looks like we'll start off with the consent agenda this morning. Do we have any changes or updates to that? Or we good to approve that?
Yes, members of the board, we do have some updates that are coming regarding the dates of approvals for the programs you see listed under the NA and MA approvals and reapprovals. We apologize. There was an error in the preparation of the document using today's date for approval rather than the actual approval dates given to the program. So we're working on getting that updated to you now.
Thank you.
So just a point of clarification. So if you all vote on the consent agenda, it will be for everything but that. And then we're coming back with updated paperwork for date corrections that somebody's working on currently. Okay.
So was our
The motion will be as modified. Mm-hmm.
Do you want me to do it? Forget every time.
I know we haven't done a public meeting in a couple months.
No.
So who's making the
Want me
motion?
to? make the motion, or would you like to?
Oh, either way, I can make it.
Okay.
So members of the board, I make a motion that you approve the consent agenda as modified and getting updated information on NA programs towards the end of the day.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Oleniki Toobola,
Yes.
Margaret Hill,
Yes.
Claire McKinley Yoder, yes. Joni Kellis.
Yes.
Linda Stanich.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
The motion is passed.
Next we go into approval of the board meetings. Director Prusek, do you want to keep making the motion?
For the board meeting minutes?
Yes.
Sure. So I make a motion that the board meeting minutes be approved as presented.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Oleniki Toobola,
Yes.
Margaret Hill,
Yes.
Claire McKinley Yoder, yes. Joni Kellis.
Yes.
Linda Stanich.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
The motion is passed.
So we're moving a bit ahead, and we have our policy analyst, Laura Blackhurst, next. Thank you.
Give the clicker.
No, it's not working.
So you'll do it for her. Yeah. Okay. You have the support of the executive assistant. Next slide.
All right, good morning, members of the board. My first item is related to administrative rulemaking on page 44 of your packet. This is pertaining potential changes to Division 21, the standards for approval of nursing education programs. And specifically, this topic is about updating the requirements around the ultimate degree awarded by advanced practice registered nursing programs. I have a very brief PowerPoint today to again highlight the proposed change and to follow up on some of the discussion and questions that you all had at the November meeting. So next slide, please. On the screen, you can see the proposed language change within Division 21. And again, currently, Oregon APRN programs are required to culminate in a doctoral degree. We are the only state that requires a doctoral degree be awarded for all APRN education types. And this does represent a misalignment of our licensing rules because you can be licensed as an APRN without a doctoral degree. And so the proposed changes are truly modifying one line in Division 21. On the second slide, again, it's a very brief presentation for you today, really summarizing the impact of the proposed changes. This does not modify any of the OSBN curriculum standards currently in rule. It does not modify faculty qualifications or accreditation requirements. It is truly increasing the flexibility for program offerings. A great example of this is the rise in popularity of postmaster's certificates, which our Oregon programs are not currently able to offer. This would also, again, lead to this regulatory alignment with our licensing standards and those national trends for APRN education. At the November meeting, there was also a question about employment and the time to employment for nurse practitioners. Dr. Sarah Wickenhagen, a fellow policy analyst, reached out to our 2 Oregon schools that are graduating NPs. That is OHSU and the University of Portland. For their most recent cohorts, they reported 100% employment at 1 year post-graduation, with many students being hired or having offers like at graduation. That really is what we expected with data from the Oregon Employment Department that highlights these APRN roles are in a lot of demand here in Oregon. So that is my brief presentation today. Again, we discussed this in November, so I hope it's still fresh. Happy to take any questions you have.
Madam President, can I jump in and just make a few comments?
Yes.
Well, so I thank you, Policy Analyst Blackhurst, for this presentation, and I just want to thank Board Member Hill for bringing this to our attention when you came back from the National Council State Board of Nursing, really talking about barriers for CNMs And then me sitting on the governor's Behavioral Health Talent Council, hearing about barriers to our psych NPs, doing a survey across the country, learning that while many programs are going towards having APRN degrees be doctorally, the terminal degree, it's not in the board's regulatory work in any other board across the country. So doing this will just remove the barriers that you came home and from National Council, both of you, and presented, and what we were hearing from the governor's task force. And just so you know, in between these meetings, Dr. Sarah Wickenhagen, myself, and Laura Blackhurst had been meeting with the schools, and everybody's, feeling really good about it.
Question. You had said there's no change in content standards. Is there any change in credit hours required for degree completion?
That is a great question. So currently in Division 21, we do not establish how many credit hours are required for these degrees, so that is not changing for us. I'm happy to bring a motion if you're ready.
I think that should be fine. It's really appreciated that the alignment with the other states. And I think this will also keep a lot of Oregonians in Oregon also without having to shuttle with schools outside of state a lot more like it is currently, because then they have a shorter time in school and they can get their degree faster too. Thank you. Think we're ready for a motion.
I motion that the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments to OAR 851-021-0050 as presented.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Oleniki Tuabola.
Yes.
Margaret Hill.
Yes.
Claire McKinley Yoder, yes. Joni Callis.
Yes.
Linda Stanich.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
The motion is passed.
Thank you.
Great. My apologies. My next item on the agenda is page 80 of the packet. This is an education item, and it is regarding approval of Umpqua Community College's practical nursing program. So Umpqua Community College's practical nursing program underwent a survey in October 2025 following the graduation of their first practical nursing cohort in order for the board to consider full approval of the program. The survey report and findings are attached, but all standards for pre-licensure nursing education were found to be met. And during my survey, I wanted to elevate that I was very impressed with the work being done at Umpqua Community College. The practical nursing program is really taught alongside, embedded with the registered nursing program, but it was very apparent on survey that this program was thoughtfully, intentionally designed, that practical nursing education is not an afterthought, that the importance of that role is elevated and highlighted in their program. They are actively pursuing accreditation through ACID, and so my recommendation is that the board grant full approval to the practical nursing program through February 2030, and that in the future our surveys would align with those accreditation surveys. Any questions about this item?
No, I think we're ready for a motion.
All right, then I motion that Umpqua Community College's pre-licensure practical nursing education program be granted full approval through February 2030.
So moved.
Second.
It's been moved and seconded. Oleniki Tuabola.
Yes.
Margaret Hill.
Yes.
Claire McKinley Yoder, yes. Joni Callis.
Yes.
Linda Stanich.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
The motion is passed.
Thank you. And congrats to the program, their administrators on the call with us as well.
Good to see you, Chelsea.
Good to see you.
It's nice to see you as well. Thank you very much.
My second agenda item, or second education item, is on page 86 of the packet. This is regarding the approval of Tillamook Bay Community College's registered nursing program, and this time I'm joined by their nurse administrator on screen. The Tillamook Bay Registered Nursing Program underwent a survey in November 2025, following the graduation of their first cohort in order for the board to consider full approval. Survey report and findings are attached. All standards for pre-licensure nursing education were either met or partially met, and the program was provided recommendations for all of those partially met standards. I want to note that anything that was partially met this is truly a brand new program, so a lot of the recommendations were just about refinement of a new program. For this program, it was very clear how important this program is to the community out in Tillamook. The college has invested many resources into building a new building. They've got beautiful new classrooms and lab and simulation space that I think are opening soon, if not open already. And this program is also planning to pursue accreditation through ASIN. So I have a very similar recommendation of we grant full approval, continue to survey in line with the accreditation cycle, but that initial approval would be through February 2030. Questions about this item?
I might have just a learning moment question
Yeah.
for the partially met item, because the motion is to give approval through 2030, correct?
Could you ask that
The
again?
motion is to provide approval through February 2030.
Yes.
So for the partially met items, at what point do we know if that was met? If we give approval to 20?
Typically on a survey, if there is something that is partially met, typically what we're doing is giving a recommendation, asking them to fix, and we'll reevaluate the next time we survey. It's really when it's a standard is truly not met or a safety concern that the board has historically asked for something to be fixed within a time frame. Yeah.
So it's more of a recommendation, not like a requirement.
Yeah.
Okay, thank you.
Any other questions? All right.
I think we're ready for a motion.
All right, then I motion that Tillamook Bay Community College's pre-licensure registered nursing education program be granted full approval through February 2030.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Oleniki Tuabola,
Yes.
Margaret Hill,
Yes.
Claire McKinley Yoder, yes. Joni Callis.
Yes.
Linda Stanich.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
The motion is passed.
All right, thank you, and congratulations, Dr. Slover, on your program.
Good to see
Thank you
you.
so much, everybody. Good to see you as well.
All right, my third education item is on page 92 of the packet. This is a follow-up report from Portland Community College's registered nursing program. For background, the program was surveyed February 2025. At that time, we had evaluated 3 standards as not met, and in April 2025, this board had directed that we issue PCC a written notice of deficiencies, and again, require evidence that those deficiencies had been corrected. The standards at that time were related to sort of faculty expectations, orientation, policies around selection of clinical sites, and really ensuring the program had clear processes to supervise students and set expectations for students. I want to commend PCC because not only have they written this report, developed new processes and policies, but when we noticed them of certain deficiencies with Division 21, we then changed Division 21 in June of last year. And so they provided a written report that both addressed the standards at the time of the survey and the standards as they were updated. So having reviewed their documentation and having conducted this survey initially, I believe there is sufficient evidence that the deficiencies have been addressed. At the time of the initial survey, they also had a number of standards that were partially met and were given recommendations. They're already on schedule to be surveyed next spring, again, in line with their national nursing accreditor. So are there any questions about this report?
think we're ready for a motion.
Happy to bring one. So this one, I motion that the board accept Portland Community College's written report as evidence. The deficiencies from the February 2025 survey have been corrected.
So moved.
Second. Been moved and seconded. We'll do a vote. Oleniki Tuabola.
Yes.
Margaret Hill.
Yes.
Claire McKinley Yoder, yes. Joni Callis.
Yes.
Linda Stanage.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
The motion is passed.
Thank you so much. Right, my fourth education item can be found on page 141 of your packet. This is regarding a substantive program change at Walla Walla University's registered nursing program. For this item, I really want to highlight that Walla Walla University has campuses in both Oregon and Washington. And so as such, they are regulated by both OSBN and the Washington Board of Nursing. And so that substantive change report that is in the packet is the report they give to their accrediting agency, but they are discussing changes that impact both Oregon campus and the Washington campus. And so there's a lot of good work they're doing. I'm really trying to focus us just on what is happening on the Portland campus here in Oregon. This does include revising their mission, vision, philosophy statements, the program learning outcomes, the curriculum scope and sequence. And these changes are really meant to align the curriculum and outcomes to national education frameworks, such as the AACN Essentials. It is also ensuring alignment with their overall institutional standards and ensuring the course sequencing is the same on both campuses and consolidating all of that nursing education into just the junior and senior years. So there's a lot of changes. Again, their nurse administrators here behind us, but I'm happy to answer any questions you might have.
I actually did have a question. So I loved the summary. It was very helpful. Thank you. If I'm understanding it correctly, it's that the teachers will basically still be in Oregon, but it'd be like almost like a Zoom link, or is that correct? Or okay.
Why don't you come join us and for the record, enter your name? No, it would be really great to have you up here. Mhm. Thank you.
Hi, I'm Carrie Firestone. I'm the Dean of the School of Nursing at Walla Walla University. To answer your question, we have faculty on both campuses. There will be some cross coverage using upgraded technology, but we do have faculty on both campuses.
Awesome. That is so cool.
Are they licensed in both states then?
They are. All our faculty are required to be licensed in both Oregon and Washington.
Any other questions?
I just want to thank you for doing this. I think this is really addresses a need in our rural communities.
Thank you. That's one of our main goals.
I will bring a motion. Then I motion that the proposed program and curriculum changes to the pre-licensure registered nursing program at Walla Walla University be approved as presented.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Oleniki Tuabola.
Yes.
Margaret Hill.
Yes.
Claire McKinley Yoder, yes. Joni Callis.
Yes.
Linda Stanage.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
The motion is passed.
Thank you so much.
Moving into my fifth education item, this one is on page 222 of the packet. This is a preliminary development application for a new pre-licensure registered nursing program from Western University of Health Sciences. Their application contains all the required components that are outlined in OAR 851-021-0010-1. which is step one of the new program approval process. This program would be located on Western University's campus in Lebanon, Oregon. They already offer programs such as a Doctor of Osteopathic Medicine and Doctor of Physical Therapy. And so this new nursing program would be a master's level pre-licensure program, of which there's only one similar program in Oregon. Board approval at this stage would grant the ability to begin really developing the curriculum, hiring faculty, developing clinical partnerships. And just as a reminder, the board would still need to approve this program again before they actually can admit students. But their goal is to launch August of 2027. So questions on this item?
I actually do have a question, and I'm not sure if it's going to be more for you or for them or who, or even if it's an answerable question.
Absolutely. Oh, they are behind us. Yeah. Apologies, I only have one chair.
Thank you so much.
Have your packet with it as well.
Hi, I'm Mary Lopez. I'm the Dean at the College of Graduate Nursing in Pomona, California.
So my question is on from page 226 on the packet, talking about planned student enrollment.
Yes.
It says the applicant pool is around 6,800 qualified applications per year statewide. I know not all of those are going to be like eligible for your program. Do you bleh. Sorry, my tongue is, how many of those applicants are actually people that would qualify for this program?
Right, that data is taken from the Oregon, from your OSBN site.
Yeah.
So that's where that statistic comes from. We're looking for people who want to become nurses who already have a bachelor's degree in something else.
Yeah.
And so there are hundreds, if not thousands, of people out there that have a bachelor's degree that want to become nurses. And we believe that master's entry is all the nurses who work should have a master's entry. That's our belief. And rather than start as a stair step, like I was, associate degree nurse, a bachelor's degree nurse, a master's degree nurse, PhD, that we should take people who already have a bachelor's degree and give them a master's degree and teach them how to be a nurse. So that's been our model. It's been successful. And that's what we're looking forward to doing in the state of Oregon.
It's definitely I had never even heard of this before. So I was like, wait a minute, I didn't know this was a thing. It's very fascinating. So.
What's the anticipated size of your first cohort?
25.
And what's the cost of your program?
Are you talking about the tuition? Right now, to become a master's prepared registered nurse takes 2 years, and it costs about $100,000.
And did the PTs really give up space, or did you?
Oh, that's the juiciest part of this, isn't it? So we have been partners with them for a couple of years, right? We've been coming up and meeting them and being with them, and they have an absolutely gorgeous building. It's better than our building in Pomona, California. But it was built, it is so large, it used to be a furniture store. And it's so large that it was built for 2 programs. It was built for physical therapy and occupational therapy. But the occupational therapy program didn't get off the ground. And so there are 3 classrooms, there's 3 simulation labs, there's, a whole arm of offices. I mean, there is more than enough space up there for 2 programs. And right now there's just 1 program in it. So there is space for nursing to be up there. And of course, that's not the hardest part. The hardest part is being neighbors, right? And so of course they've spread out and taken up all that space. And are they willing to take the space that, and so, they say yes, and when we go up and talk with them and be with them, they're very lovely people and yes, you can have this classroom, and yes, you can have this space to develop a simulation lab, and yes, there's enough parking for you, and let us take you to our favorite restaurants. And so they've just been really good neighbors. And they know that financially, they cannot continue to pay with one program for that whole huge big space. So they're actually looking forward to a program to come up and occupy this space with them for financial reasons. Has not been a problem.
Thank you for the detail in this, and I appreciate this program coming in. I lived in Lebanon. I lived right across from Western for the longest time, and I knew when that furniture store was bought and how that whole thing went. My curiosity is going to come later on. I have some questions and hesitancy about this, not just the space, but the location and like clinical rotations and things like that. And just to confirm that this is going to be fully in-person program, correct?
Yeah, right now, our pre-licensure program is an on-campus program, and that's our intention to have it on campus here in Lebanon. But we also understand that weather here in the Oregon area is different than weather in Southern California. And so we will have the capability of transferring our curriculum on a need to basis to being online if we have an ice day, for example, and the students can't make it into campus.
Thank
Our
you.
intention is to have it on campus.
Thank you. And it really helps to know like the other program in California is going to kind of be like a model for the one going on here. So that gives a bit more safety net of kind of planning for the unforeseen things. Thank you.
One more question. Just out of curiosity, I'm sure the program is already in the works as far as in the mind and what's going to happen. Would that be coming back to us at the next meeting for our next approval, or how long does that generally take?
We have already talked about what our curriculum would look like. We've already been out to our clinical partners for the last 2 years, seeing if there is actually a need for us to be there, because if we don't have clinical spaces, you can't run a nursing program. So that background work has already been in place for a couple of years. We just are following your process to make sure that we do everything right and get your preliminary approval. But we've had our board of trustees sign off on this. Our president and provost are excited. Our clinical partners, we put one letter of support in our packet to you. So, we've been doing this background work for a while so that we'll be ready to pull the trigger when the approval is there.
I guess we're ready for a motion and we'll look forward to the next step.
Bring this one. So I motion that Western University of Health Sciences preliminary development application for a pre-licensure registered nursing program be approved as presented.
So moved.
Second.
Been moved and seconded. We'll do a vote. Oleniki Tuabola.
Yes.
Margaret Hill.
Yes.
Claire McKinley Yoder. Yes. Joni Callis.
Yes.
Linda Stanich.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
The motion is passed.
Thank you.
Thank you. All right, moving into my sixth education item. This one is on page 245 of your packet, and it is regarding revised end of program outcomes for the registered nursing program at Lynn Benton Community College. I don't believe I have a rep from the school for this one. So for this item, new program outcomes were implemented following some faculty development and through an internal approval process at Lynn Benton. The outcomes changed in January 2025. At that time, the program was not aware that program outcome changes required board approval. Once the program became aware, they immediately reached out to initiate the process of asking for board approval to update these outcomes. And as I reviewed the revisions, I also want to highlight that the changes to the program outcomes were more about like readability and clarity. They weren't truly changing the intent of the program outcomes. Nevertheless, that is the ask today to consider approval of these outcomes. Any questions on this item?
Another curiosity question. How did they become aware that they needed to notify the board?
I am happy to tell you. So we have begun offering new dean and director orientations because we see a lot of turnover in our deans and directors. And so it's an opportunity to connect with these new deans and directors. I think a few behind me have been to this orientation. And really talk to them about what do the OARs say? What are the expectations for you and your role in your program? What are the things that you need to be aware of will either require you to notify the board or get the board approval? And so that is where the discussion occurred. And a new dean or director identified we had a change that required board approval.
Thank you. That's a good learning moment.
And members of the board, I just want to commend Laura Blackhurst on creating that program and offering that program. It's been attended every time she's offered it, and I think it's going to really help.
It's very popular. So we are expanding it.
And just a question on page 250, it says, little tiny bit, upon further review, nurse leadership team is determined to continue to improve wording of EPSLOs. We'll bring to CIC in December for approval. I'm assuming that
Yes,
I haven't up.
I believe that is like a historical footnote at the top of page 249. We have the approval date by faculty, and I think they were basically doing continuous quality improvement. So I don't think the outcomes have changed again, but they are continuing to see now that we have these new outcomes implemented, are they working? Any questions, or can I bring a motion?
I think we're ready for a motion.
I motion that the Lynn Benton Community College pre-licensure registered nursing education programs be approved as presented.
So moved.
Second.
Been moved and seconded. We'll do a vote. Oleniki Tolbola,
Yes.
Margaret Hill,
Yes.
Claire McKinley Yoder, yes. Joni Callis,
Yes.
Linda Stanage,
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
Motion is passed.
All right, my seventh and final education item. This is on page 251 of the packet. This is regarding some program change requests from Lane Community College. I actually have two asks in this memo, so if it is all right with the board, I'd like to discuss one, do a motion, and then discuss the other, do a motion just for clarity. The first ask is a request from the Lane Community College Practical Nursing Program. They are wanting to update the practical nursing curriculum to be able to really integrate it fully into year one of the RN program curriculum. This strategy is very popular. It allows for better sharing of faculty and resources. Students can actually take the courses together. And the RN program has already been given OSBN approval to have students take the practical nursing NCLEX after year one of the curriculum. And so it really makes sense to like merge these two curriculums. And so the request, if approved, would allow the practical nursing program to officially update their curriculum to be the first year of the RN program. We have a couple representatives from the program if there are questions, but I'll try to answer if there are any.
I was just going to say, I appreciate the, I think somebody else said something about like kind of a stair step approach, because I think that is one way that we get a broader spectrum of nurses with different backgrounds into the program, because not everybody can take time off to do a bachelor's or graduate entry program. And so I appreciate having these additional ways for nurses to enter.
I will bring the first motion. So the first motion is I motion that Lane Community College's pre-licensure practical nursing education program and curriculum changes be approved as presented.
So moved.
Second.
Been moved and seconded. We'll do a vote. Oleniki Tolabola.
Yes.
Margaret Hill.
Yes.
Claire McKinley Yoder, yes. Joni Callis.
Yes.
Linda Stanich.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
Motion is passed.
The second request from Lane Community College is for their registered nursing program. So for context and background, in February 2025, OSBN approved a demonstration project for a new LPN to RN and paramedic to RN bridge program. A side note for the board, at the time, Division 21 described this request as a demonstration project. The updated OARs refer to it as an innovative approach. So this is why I have a little bit of jumbled language in the memo and describing this. The wording in our rules has changed. However, the ask from the program is that they would like to continue trialing these new pathways after their initial cohort, and they'd like to admit a second cohort while they continue to really study the effectiveness and outcomes from these new bridges. So if approved, the program, these bridges could continue and expand. Any questions?
I do have a question. So it was first, I think I have different staircase approach to my question. How did the first cohort do?
That is a great question. I know that it was very popular and successful, but I am going to turn to their nurse administrator. Dr. Tavernier, would you be willing to tackle that?
I would love to. The students are doing very well. We set up some protections for them by the way of some online resources for pathophysiology, pharmacology, courses that they could study. They also were given permission to join our first year cohort for pathophysiology, pharmacology. We put together a pretty extensive study guide for them using some Kaplan resources, and the students haven't used them. And Dr. Miner and I, our division dean, have been meeting with the students every term and asking how they're doing. And they feel that they came in very well prepared. They feel that a lot of the curriculum is actually redundant. They feel like they could move through faster than they are. So they far exceeded our expectations.
Thank you. So maybe I'm missing this. When are they set to graduate? Or did they
The first cohort will graduate this June.
Okay. Thank you. So the request now is to do another cohort now before knowing how the first cohort do with their exams, correct?
Yes, the ask is to kind of those timelines with admitting new students and getting them started. They would like to begin the process of admitting to that second cohort. I think that will begin probably before they finish and graduate.
Thank you. I think my only concern is not knowing a full cycle of how the first group did, so you can know what are the lessons learned. I do hear that you've had some feedback that some of the information are redundant, but to be able to see like how the full cohort does with their exam and then take learning moment to put it to give the next cohort a better experience would have been my thought.
So our students are using the Kaplan NCLEX prep guide, and the students have been scoring very well on their exam. So we have an indication that they will do well. They will also take the Kaplan readiness and predictor exams before the next cohort is admitted. So if we were to find that they weren't doing well, that would give us some time to study where the holes are and be able to make sure that we can provide the next cohort with the educational resources that they would need to be successful on that.
Thank you.
I do want to add that because this is approved, it was approved as a demonstration project, it's now an innovative approach. It is an expectation that these programs report back to the board with outcomes. So they don't have them yet, but we will ask.
I just want to really, like, say, you guys are doing a great, I think it's a great job with the LPN to RN bridge pathway, especially reducing, the amount of time. I at one point was trying to become a nurse, and LCC is my home area. So I was looking into doing the LPN program and then doing the bridge, and it was like, okay, it would be basically the same amount of time. I'd have to do the LPN program and then basically do the RN program with doing the bridge. So I love seeing that you guys are taking it and being like, yeah, so LPNs do know something,
I think we're ready for a motion.
I motion that Lane Community Colleges, LPN to RN, and paramedic to RN innovative approaches be approved to continue and expand as presented.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Oleniki Tuabola,
No.
Margaret Hill,
Yes.
Claire McKinley Yoder, yes. Joni Kellis.
Yes.
Linda Stanich.
Yes.
Rachel Dennis.
Yes.
Alipa Nesta.
Yes.
The motion is passed.
Thank you. Those were all my items.
I think we should take a break.
Yeah, Madam President, members of the board, so we are almost an hour ahead of time.
Yes.
So I do think it's a good idea that we take a break. And then, of course, I can move my very simple agenda item up. And then we're trying to contact our presentations today. We have some information from OHA workforce. We have information from Oregon Wellness Program updates, and then a presentation on just culture. So we're just going to see if we can get them to change their times a little bit, and then we can update you when we get back from the break of what we learn. But yeah, I think you noticed we kept today's public meeting simple given how much work we did last year. So do you want to do 10-minute break, and then we can see if we can know what's can happen from there?
Sounds good. Okay. We'll be back at 10 o'clock.
Madam President, members of the board, good news. Our OHA workforce presentation is able to be done an hour early at 10 o'clock instead of 11. So just by way of why I wanted to add this to the agenda for you all was on September 16th, 2025, during the Strategic Planning Day, OHA had presented on the Healthcare Workforce Reporting Program. And some board members had questions at the meeting. And so I met with them. I actually meet with them monthly, given they lead on all of the data collection that is collected on our applicants and their application process. But at this meeting, we discussed the questions that you all had, and especially board member Callis had questions. And I wanted to make sure they came back and shared the answers to that and gave a context to what they presented then and the questions then. And if you don't remember what they were, they will remind you. So I'm excited they're able to join us today. So September board meeting was when they presented. November was a full board meeting. They couldn't come, and here's our second board meeting since then. So welcome. If they can hear me, they can turn on their cameras and introduce yourselves and present. And once you're done presenting, we'll have a little discussion.
Fantastic. That sounds great. Can you all hear me all right?
We sure can.
Great. So hello, good morning. My name is Meredith Halling, pronouns are she, her. I'm a research analyst with the Healthcare Workforce Reporting Program at OHA. I'm joined today also by my colleague, Andy Davis. Andy, do you want to come on camera and introduce?
Oh, I'm not sure how much I really want to be on camera, but hi, I'm Andy Davis. I'm also a research analyst. I'm going to be trying to just run the PowerPoint in the background while Meredith presents today.
We also might be joined pretty soon by our manager, Piper Block. But until then, we can kind of just jump into things if that works.
I appreciate you jumping in early and helping us out with our agenda, so thank you.
Yeah, no problem. So Andy, are you able to share your screen? Fantastic. If we could go to the next slide. So we just wanted to start with a brief reminder of our team and where we sit within OHA and kind of who we are. So that we are the Healthcare Workforce Reporting Program, as we said, and we sit in the Office of Health Analytics at OHA on the Research and Data team, which is managed by Piper Block. The team also includes the Hospital Reporting Program and the All Payers, All Claims database program. We also work pretty closely with some entities outside OHA that are shown here, including the health licensing boards, the Oregon Health Policy Board, and specifically the OHPP's Healthcare Workforce Committee are the groups that we interact with pretty frequently. Can we go to the next slide? Thank you. So the Healthcare Workforce Reporting Program collects data from 17 health profession licensing boards. And that data is collected as a part of the license renewal process. So it's collected with an online survey that is taken when licensees renew their license. So that data is collected every 1 or 2 years, depending on the board. So 2 years for OSBN. And first-time licensees do not take the survey. And this data is leveraged by lots of groups who want to understand healthcare workforce in Oregon. So both internal to OHA and external. Next slide, please. The data that is collected by the survey it is roughly outlined in statute what is collected and kind of shown in those buckets here. So we have provider demographics and background, practice patterns, and practice location specific elements like work address and hours that are worked. Let's go to the next slide. So we were asked to come back and to present because as was already described, when we came in September and presented some healthcare workforce data on the nursing workforce, a question that came up was how well the Healthcare Workforce Reporting Program data aligns with the minimum data set recommendations specifically the supply recommendations developed by the National Forum on State Nursing Workforce. So we compared the healthcare workforce survey questions to the most recent version, to the 2024 version of the forum's recommended data elements. And we went through and we categorized the MDS variables into 3 groups that are kind of shown here on the right-hand side in this box. So we kind of describe the variables as either with the green arrow, so meaning that the minimum data set variable is collected by Healthcare Workforce Reporting Program, pretty directly comparable. The yellow dash, which indicates that Healthcare Workforce Reporting Program collects similar information, but just maybe in a way that's not an exact match with like the structure of the question that is on the MDS. But that information is still collected in a way that could be comparable. It's just not the exact same kind of question and response options. And then finally, the red X kind of indicates that that data is not collected by Healthcare Workforce Reporting Program at all. So let's go to the next slide. So the minimum data set variables that are recommended by the forum are grouped into these 6 kind of overall categories of characteristics. And they recommend that at minimum that this group, the group 1 and 2 variables are the ones that they kind of want states to prioritize. Next slide, please. I'll just jump into this. So for group one are variables that are needed to estimate the current size of the nursing workforce in the state. And healthcare workforce collects comparable data for most of these recommended variables. So for active nursing licenses held, advanced practice, registered nurse certification, employment status, and employment location. The only one on this in this group that is not collected is information on multi-state licensure, as Oregon is not a member of the Nursing Licensure Compact. Next slide. So for group 2, variables needed to estimate or create projections for future size of the nursing workforce. Birth year, of course, is collected. For year of initial licensure, Healthcare Workforce Reporting Program has Oregon-specific year for a licensure, so we would know the Oregon-specific year. But we also have a question that says that asks for the year that the licensee completed their entry-level nursing education. So we have information that could kind of be used to get at that. For variable number 8, intent to leave the workforce in the next 12 months. On the licensure survey, the OHA survey, the timeframe is 2 years. So that is kind of, we have this difference there. Next. So for group 3, demographics and education, we do collect gender, we do collect race and ethnicity. Both of those have slightly different response options, but could be comparable there. And for variable 11, we do not collect state of residence. We don't ask where people actually live. We only ask for information about where they work. So that one, we would not have any information for that. For group 3, this is just a continuation of the demographics and education. For variable 12, all nursing education programs completed. This one scored a yellow because we don't capture all programs. We ask about entry level and highest education. So theoretically, if there was a middle, if there's more than 2, then we would not have that information. And then for country of initial licensure, the Healthcare Workforce Survey has country where licensee received their entry level nursing education. So we could we have some information but not exactly aligned with that. And then we do have information on highest level of non-nursing education completed. We have a question that asks if licensees hold any other degrees or certification that are not directly related to nursing. So like an MPH or a JD, anything like that. For group 4, employment and practice variables, we have most of these as well. For the variable 15 that has the yellow, the number of nursing positions held, we ask for primary and secondary. So theoretically, if a nurse is working in 3 or more, we wouldn't have information on that. specifically, but we do ask total hours worked, position classification, and employment setting. And then a few more employment variables and practice variables. We ask all of these in a directly comparable way. So position title, practice specialty, the amount of time spent in direct patient care, if telehealth is a part of their work, and then travel nursing. For group 5, well-being related variables, the healthcare workforce reporting program does not collect information on student loan debt or any information on well-being. Next slide. The group 4 variables are on employment and practice. So for variable 26, we don't have this level of information about if an individual holds a license but is not working in a nursing related position. We do ask an employment status question that includes options like retired or unemployed but seeking work in the field. So depending on the question, we may be able to provide information about that. And then for variable 27, seeking work as a nurse, we do have a response for that, the unemployed but seeking work in the field. So I know that was kind of a whirlwind run through there, but overall, we found that the variables in the healthcare workforce reporting program survey and the minimum data set recommendations are pretty well aligned. There are some minor differences, but I think for many research and policy questions, the data that is collected on the survey would be able to be analyzed alongside data from states or organizations that are using the current MDS recommendations. And that is all. And I will also note we can send, of course, this this slide deck out to you all, as well as the full like MDS variables, so you can like have that information to review if you would like.
Thank you very much. That was detailed, but still quick and well put together. And we will definitely appreciate the presentation. I think we have a couple of questions for you.
Of course, sure.
I was wondering, has there been discussion about adding the well-being questions specifically around debt? Because with the recent change in federal rules around nurses' ability to access loans, I think it would be helpful for us to have some data about, it may be helpful to have some data about that.
Meredith and Andy and Piper, do you want to take your slides down? And of course, I'll be able to add context to this, but I think I'd love to hear how you all want to answer that. And then I can add some context.
Sure, I can start by giving a quick answer. Hi, everyone. I'm Piper Block, she, her pronouns. I'm the Research and Data Manager in Office of Health Analytics. I manage this program as well as 2 others. And so I guess I would start by answering that question, that any changes that we're considering, we would partner with all 17 of the licensing boards to discuss and decide as in partnership. So we don't have any current plans to add questions to the survey. There is, like, technology-wise, there's capacity to add questions, but we would certainly defer to the nursing board as well as the other boards in partnership to decide whether that would make sense for everyone. We know that there's also a lot of respondent fatigue with the questions. So we want to make sure that if there is any decision to add questions, that it's really intentional and is worth the effort. I think that I agree with you that information seems really important. So we are certainly open to that discussion and would want to support any further questioning into whether questions should be added to the survey. But again, want to just make sure that we're doing that in partnership with all the boards.
Anybody else from OHA want to add to that before I jump in? No, okay. So, Board Member McKinley Yoder, I appreciate you asking that question, and I just want to, acknowledge the work that I've done with OHA Workforce and all of the other health professional regulatory boards that I meet with monthly. There was a proposal from OHA to add wellness questions onto our extensive questionnaire as is. The way the questions were going to be asked, the medical board director and myself had conversations with the other 17 health professional regulatory boards about the concerns of how we are moving away from asking things like, how are you feeling in burnout, and then rate it. And then, they went into, I don't remember exactly, maybe you all do, so I apologize that I don't have this pulled up, but, are you at the end of your rope? Like they were being pulled from not necessarily the PHQ-9, but something similar. And I felt very uncomfortable if there was not somebody on the other end seeing that and following up. We cannot ask our healthcare professionals about their wellness to the point where we're saying, are you great or at the end of your rope, without making sure there's some kind of follow-up. So we had extensive discussions about ensuring that, I think it was maybe 3 questions that were going to be added, and moving forward how we can discuss it. So this is a perfect opportunity for this board to, whenever you want to, have that discussion. And I can, work with the other boards about their thoughts. But it truly is, as mentioned, how we ask, what happens when we answer, and then the fatigue of, I know you all wrote it takes 5 to 8 minutes, but I'd like to challenge that a little bit and say it takes 10 to 12 on top of what they already answer on ORBS. But again, I feel very strongly that we're collecting the right data. I wouldn't want to not do this, but how it is one of the complaints we get from our applicants of why are they doing this all the time? And, our staff has been supported in explaining that. I do think, though, with you mentioning what could potentially happen with funding, and that's another thing boards of nursing are talking about across the country, what that might look like on a questionnaire. And, it's happening to other health professional regulatory boards that are within the 19 that I meet with monthly. I don't remember, it's physical therapy, social work. I can't remember which other ones are a part of it. But maybe that is a question that gets added. And I don't know what it would be. Like, would you further your education if you got loans, or were you not able to because you didn't get loans? So that is something that potentially we can consider. But when it comes to wellness specifically and burnout, it really was a concern.
I apologize. I was responding specifically to the wellness question. There were like 2 up there. Well, and one was around specifically debt.
Yeah, no, and
that
that's
was the one I was responding to. I wasn't, I wasn't aware of these other extreme burnout ones.
Yeah, and I haven't had the opportunity to bring it here, so that's why it's nice. What is the one about debt? If you could share that again, I'm sorry, because I don't remember it. And you saying it's on the minimum response, but not on ours? And maybe it can be?
Yes.
Okay.
This variable 24 about student loan debt is not included in healthcare workforce data.
Yeah, and I agree. There's nothing about that that's saying, that would be linked to like a PHQ-9 type response.
And I guess the other thing is, and okay, forgive me if this has been changed, but there were questions about like, can you toilet yourself? Can you wash your hair? And for a profession, I mean, we're already asking questions. Are you able to practice? I feel like you would get so few yes responses to that versus this is something that seems like it could be used and would be a much higher percentage of people.
It's almost like I handed you talking points and I didn't, because I totally forgot. That's another one. That's, if you guys want to take the slide down now, that is the second most common issue that people write to us about and feel offended, especially those nurses that are aging while they're working. Is this some type of ageist question? And so I was getting calls about that and spoke with the three people joining us today, and we came up with a solution on that. I don't know, Andy, if you want to speak to it, you could probably speak to it better than I, but they addressed it. I don't know, did that start this year, January 1st, or?
Yes, so we've added an additional disclaimer or clarified the disclaimer about how that data is being used and what it's based on, to make it more clear to people that it's really not trying to measure aptitude for your job or qualification, that it's just collecting information and it's based on some national standard.
And remind me, is it about ability, disability? I can't quite remember, but that's what I recall and how we're trying to support those with disabilities and work, but I can't remember
Yeah,
exactly.
that series of questions is designed to measure prevalence of disability in the workforce overall and seeing what the representation looks like in the different workforces, not just the nursing workforce. And so, yeah, again, it's not really trying to measure aptitude for job at all. It's just it's an extension of our Real D demographic data collection. Really, the D in Real D is disability, and so we're trying to collect race, ethnicity, language, disability data.
So just to jump back in, has that been a conversation that board members bringing up about potentially adding the debt question from the other questionnaire to align with it? And if it's never been brought up before, I can definitely talk about it with all the directors of the health professional regulatory boards and connect with OHA if that's something this board thinks is helpful. Have you all ever had anybody think about adding it on, or was there a reason not adding it on before? Okay.
At least during my tenure with the program, I don't believe we've had any discussions about that. I don't know if if there's any that predates me. I think one thing to just throw into the mix too, Director, is that we do have some custom questions for different boards, including the nursing board. There's a couple of questions on our survey that are unique to OSBN. And I think that if there was a desire from OSBN to ask a specific question, and the one that we had up on the board was about debt associated with the nursing program, not necessarily school debt in general, that, you know, it's conceivable we could just add a one-off question without all of the boards agreeing.
That's good news. Thank you for that. So we will definitely discuss that, and I can bring it back as an agenda item in a public board meeting and anything else you guys are thinking. Okay. I'll stop and you guys can jump in with questions.
I just wanted to thank you, Director Prusak, and all of you lovely folks from OHA for going back and looking at what data Oregon collects and then compare it to the minimum data set. So I really appreciate that, because I think it's great to look at data in Oregon, but being able to compare it across the country puts a whole new meaning behind it. So I really appreciate the work. Thank you.
I was just going to say thank you so much. I think looking at those questions from this perspective kind of helped us think a little bit more. And now we have another additional one that we might want to put on there. We appreciate the presentation. It was really detailed and really helpful just to get a good idea of what goes on in the background with those questions.
Yeah, and I saw some of the board members taking pictures. I don't know if there's any way you can share those slides. But again, yeah, you know, I've shared with the board that we meet monthly. You all are great partners. We have spirited debates about, you know, having the right data, collecting data, protecting data, data fatigue, but also potentially adding when needed. So it's good to know that you followed up on a board member's question, and we're willing to come back and look forward to future work.
I have one more question. When you publish this data, how current is the data you have available to the public?
So we have we create an annual data set that's accurate as of January of each year. And then our program we have a data dashboard that is available publicly, as well as a diversity report and a supply report that are published every other year.
Thank you.
And so depending on the, when someone answers a question, we have some boards that are only renewing licenses every 2 years. So sometimes data can be up to like 2 years old, but it kind of depends on the structure of license renewal for the boards. So in your case, it's just, we don't have a long lag time of having to process the data. So we do get, from the time we get all the data in January, we post pretty quickly after that to update the dashboard. And then our reports happen when we get the data in January by like the end of the year.
Since you asked one more question, I will too. If OSBN decides to add on a question around debt, is the timeline, would that be January 1st next year? How does that work? Since I've mostly told you not to add anymore, and now we might add.
I guess my take would be that we usually try to implement new questions in the January timeframe because it roughly aligns with when we collect and then process data for the reports like Meredith and Piper were talking about.
Perfect.
On a one-off question that's mostly used for internal board purposes, and especially since you have a rolling birth date based renewal, I think you could start collecting data on a new question anytime and it wouldn't necessarily be disruptive. Yeah, that would be my feedback.
Well, and I can answer now. Having $130,000 debt for many, many years, it was very, 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 very stressful. And it's also why I don't go back and get my doctorate or PhD. So there you go. I'm the first to answer the question we may add. Okay. Thank you.
Thank you so much. I don't think we have any more questions. Oh,
Okay,
yeah.
this is just a question. So, and I'm sure you have really good reason for this, but thinking about that survey fatigue piece, is there a way that you could ask a question around disability and then feed into all of those individual questions? Because I feel like that's also like survey fatigue is a real thing, but yeah, I'm just wondering, does everyone need to answer every one of those? But you probably have reasons for that.
I don't know if anyone else wants to try that. So we have based our battery of disability questions on recommendations from the Equity and Inclusion Division at OHA, and especially when we created the questions, they were the part of our agency that had the most expertise in that area and were, recommending a particular set of questions to us. I think, ultimately there's a portion of this that is up to the boards, the group of boards that that are agreeing on what questions we ask, and if they were had a strong preference for trying to make a filterable question like that, I think we have the technical capability to do that. But that's where we came to the question set that we have, was taking the recommendations from Equity and Inclusion Division and then trying to implement that with the cooperation of the boards. We did alter them a little bit with board feedback, so they're not exactly what Equity and Inclusion recommended already. But I think that's why we have what we've got.
I think you have to consider too that with like question fatigue, a lot of the people who might be getting more of that question fatigue are the people that you would want to answer those questions. So it's kind of a.
Well, and I think, this is one of those subjects that's a bit, hopefully it's okay to say this, public meeting, but taboo. And it's something that, especially in our field, it's been a challenging conversation for people to lead on, is who can have a disability and go into nursing school. And I'm proud to say that, the Dean of Linfield, Paul Smith, is leading on this work. And I know they're just got accepted to present on the work. We're going to have them do a guest article in the Sentinel. So it really is the right time for us to start talking about this a little more and what it looks like. So I can commit to you all as a board to continue to talk about the debt question, as well as the disability questions with all the other boards and OHA, and come back to you with updates. I see your hands up, Piper.
Yeah, this is Piper. Just one more note about those questions is I think it might be difficult to have a screening question because the disability questions are not all written as like, do you have this type of disability or that type of disability? Some of them are around your like daily activities abilities. And so I think that some people who may have some of those limitations would not necessarily identify themselves as having a disability. And so they may answer no to a screener question. But then if they were given the chance to answer some of those later questions about daily activities, they may answer yes to those limitations. So I think that there are certainly some really important considerations about the idea of a screener question.
Yeah, and it does go to this bigger picture, though, of, who are we as nurses and nursing professions, and who, there's so many different ways to be a nurse. And I think the conversation around grappling with, can you be a nurse with this display? So I'm excited that this conversation is happening. We will track it and follow it as opposed to the way the questions were asked now without what I had asked OHA to add on. People were feeling like, so now that I'm getting older, you're asking me if I can still do my job. It was a real interesting thing to hear people call and tell me.
I really appreciate the conversation because it made me think about things in a different way of if this is screen a question or not screen a question, and understanding that where the question is posed to nurses and LPNs, they're professionals that will be able to identify that I still need help with this and that. And also trying to take out the ageism and things and not make it so awkward for people, but also keeping in mind that people know that they have limitation and their reality of like, I'm going to retire in 12 months or in another 12 days or something like that. But thank you so much for the presentation. Okay, I think we're good. We'll be looking forward to the slides.
Okay, so Madam President, just to catch you up, we are at 10:35. We are not going to be able to have Oregon Wellness Program come early. Our lunch presentation person may be able to come a little bit before noon. I can do my one item, and then we will just have to take a break. And yes, but we need to update. Yeah, and then Michelle Bell is working on making sure the forms are updated so that we also do that. But they're not yet, right? We need to do, oh, they are done. Well, why don't you come forward and present to the board for your first time, just to make a motion, since we removed it from the consent agenda and I'm putting you on the spot.
Sorry.
Hello, members of the board.
I'm trying to figure out where you're located.
Here, let me give you.
Yes. Yes. I have to go back to the page number. I think I found you.
And for everyone's reference, it was originally page 13.
Okay, thank you. I was trying to find the number. 13. All right, I think we're ready.
All right. Thank you, members of the board. Reviewing, this was part of our consent agenda. There was some confusion in its preparation about which date should be listed for the approval. We've now updated that to reflect the actual approval date that's been provided to these programs. So we see we've got 5 new approvals since our last meeting. We've got Tillamook Community College Nursing Assistant Program, reapproval for 2 years. Date of approval was November 5th, 2025. We have a new Med-Aid program by Graystar Institute out of Beaverton. They were a 6-month initial approval as of November 24th, 2025. Another new Med-Aid program out of Bellevue, Regency Pacific Med-Aid program, another initial 6-month approval as of January 6th, 2026. Reapproval for 2 years of Clackamas Nursing Assistant Training, January 16th of 2026. And then reapproval for 2 years for the PCC Nursing Assistant Program as of January 22nd. Any questions?
So just to clarify, for the initial ones, the initial, the second and the third one, and those are for 6 months, and the reapproval are for 2 years.
The 6 months are for brand new programs, so we resurvey within 6 months, just really for a check-in to make sure things are going okay.
Okay, thank you.
Standard reapproval is 2 years once they're up and running. All right, I move that the NAMA program and prohibition updates be ratified as presented in this updated document.
So moved. Second.
It's been moved and seconded. We'll do a vote. Oleniki Tuabola.
Yes.
Margaret Hill.
Yes.
Claire McKinley Yoder, yes. Joni Callis.
Yes.
Linda Stanage.
Yes.
Rachel Dennis.
Yes.
Felipa Nesta.
Yes.
The motion is passed.
Thank you.
Thank you for letting me put you on the spot for your first time presenting to the board. Yeah, so Madam President, members of the board, if you want, I can move up my one administrative piece and then we can break. And as soon as lunch is here, you could eat lunch early and then have the noon presentation.
Absolutely.
So I really wanted to talk to you about our April board meeting. So just to kind of level set and bring everybody up to speed, in 2024, I had conducted a listening tour in the rural parts of the state. And upon my return, the board voted for us as a board to travel to rural parts of the state in 2025. And as you know, we visited Southern Oregon and the coast, and we did have plans to go to Eastern Oregon in April. I heard from many of you about the challenges of commuting really far to Eastern Oregon. And because of this, I worked on how I could travel to Eastern Oregon to represent the board. And next week, I'll be traveling to Ontario with policy analyst Michelle Bell, policy analyst Laura Blackhurst, as we do surveys on RN programs and CNA programs. And while there, I've been able to organize a listening session with the nurses in Ontario. That will be the nurses that represent FQHC clinic that's in Ontario, the hospital that's in Ontario, and the public health department that's in Ontario. And so it will really allow me to, show presence of OSBN in Eastern Oregon, but without having us all travel many, many hours. And it was a lot on board staff as well. So because I heard from you all, I wanted to bring it here to this public meeting. Since we did vote on having our board meeting in April, we would have to have me take a motion, make a motion and have you vote on it, that we would hold our meeting here in April. We still will have a strategic planning day, if that's all something you still want to do. But we will do it here or in the area. So just open up for discussion about that.
Just a clarifying question on this strategic planning day, because we've done it in October before, so it's going to be April of this year, though.
Yeah, so when we voted for it to be in April instead of the historically ones we've done in September. We're not having a board meeting in September this year because we moved our board meetings to every other month. We'll have 6 board meetings instead of 5 board meetings, and it won't be in September. And so you all chose to do it in April. And I plan on sending, after this board meeting, a survey out for what you all are interested in learning and having presented and discussed, on top of course, the opportunity where I tell you where we're at with the strategic plan and DEIA plan.
How does everyone feel about moving our meeting for April here? Anyone feel strongly about going to anything?
I'm just wondering, like, have we like, how do people there feel? Like, have you talked with folks?
So I had not made a plan for us for April after hearing from almost every board member. And so I had not made those plans yet, was waiting to see what happened here. But I can tell you that the nurses are very excited that I'm taking a day with them, and we're setting up in a conference room at the FQHC, and I'm going to be able to talk there. Mhm.
Thanks. I don't, that they're the one place that we didn't go. And so I just want to make sure that they don't feel like they're not being heard, but you will be hearing them. They
Yeah,
rest of
yeah.
us.
Yeah, no, but I hear you. I mean, my favorite part of our listening tour was the retired mental health nurse that sat in our entire meeting with her oxygen and said she'd been wanting to attend a board meeting for 50 years and sat there. That meant a lot. It made it all worth it. I'm not saying we'll never go, but right now it just seemed like a lot. You guys have traveled a lot. You have done a lot. We have moved a lot of work. So maybe it will still happen, but just not next month. If, of course, you vote that way.
I think we're good. Thanks.
So I will make a motion that the board approves our April board meeting be held at the OSBN office instead of Eastern Oregon.
So moved.
Second.
It's been moved and seconded. Let's do a vote. Oleniki Tolbola.
Yes.
Margaret Hill.
Yes.
Claire McKinley Yoder. Yes. Veronie Callis.
Yes.
Linda Stanich.
Yes.
Rachel Dennis.
Yes.
Olipa Nesta.
Yes.
The motion is passed.
So then the one other thing I wanted to remind everybody is I've sent you all an email about the CLEAR conference. We're very lucky that the Council of Licensure Enforcement and Regulation, CLEAR, and International Resource for Professional Regulation will be in Portland, September 14th and 17th. I sent you all an email. I've heard from 2 of you thus far, but we don't have a board meeting, which typically we can never attend the CLEAR meeting because it's during a board meeting. So I wanted to support the opportunity for any board members who want to attend, just to let me know, and Brandy will register you. And it's, September 14th to 17th. You can go, the whole time or what days work from you. And I'm sure some staff will be in attendance as well. So that's my only reminder. And then the rest of the day today, we have a presentation from Oregon Wellness Program and a presentation on just culture, and then our public open forum. So for now, it's break until 10 minutes to noon, and we can let you know when lunch comes. And it seems lunch will probably be ready at 11:30. So if you want to plan break, lunch 11:30, come back in shortly before 12. The presentation for 12 was going to come as soon as he could, but he didn't know if he could get here much earlier. Okay.
Thank you. We have a long break to catch up.
Recording in progress.
Thank you for joining us. So we'll proceed with our item for lunch and learn on just culture. If you don't mind introducing yourself first, and you push the mic on. Thank you.
Good afternoon. Or still good morning for a short period of time. My name is David Allison, and I'm happy to be here with you today and share some of my experiences with Just Culture. And I brought my colleague, Molly. I'll let you introduce yourself.
My name's Molly Rank, and David and I are business partners in a consulting arrangement. And I am here to support David and add anecdotes if requested or opinions. My role in healthcare is as a lean leader, and I have an engineering background.
Oh, let me share my screen. Wow, is it coming through? Yeah. Okay, thank you. So I've got about 17, 18 slides to go through. It's not an hour's worth of material, so I think that there can be some conversation along the line. One of the last slides I have actually has some points for some discussion. So you feel free to ask some questions along the line, but there should also be a pretty substantial amount of time for us to have some conversation, questions and some discussion toward the end, which I'm happy to do. So what I'm presenting today is based on my experience, about 35 years in healthcare, with a background in both behavioral health, risk management, and patient safety. And most of this thought around Just Culture came from my experience leading a patient safety program. But these are my own views. I'm not representing any particular company. So I did want to just ask, Just Culture, I think, is familiar to some in healthcare, but not universally. I'm curious how many of you would say that you have heard the term but not really sure what it means, or how many of you have some background in Just Culture? Are there those of you that really feel like you could be leading a discussion about Just Culture? So how about those with just some exposure but not really clear or never heard of it? Okay. How about those with some background and experience with Just Culture? Okay. And anybody who really feels like you've been immersed in it and got a pretty good, did you raise your hand? No, okay. Yes, all right. So feel free to jump in. All right. It's not advancing, what's going on? There we go. So this is what hoping to cover today. One of the points that I have seen is that I don't know that there's a great appreciation for the background or where Just Culture concepts and framework came from. So we'll dive into that. And looking particularly at a psychologist, James Reason, who, as we'll get into in a moment, really is the person who coined the term Just Culture. And then that leads into some consideration of human factors, which could be another hour or day of conversation. And then from there, I thought we should end up with what are some of the maybe common misunderstandings about Just Culture that would be good to talk through. So just in terms of context and background, any of you who were around in 1999 when the Institute for Medicine published To Err is Human? Yeah. So I remember the IHI conference. It was still the Institute of Medicine at that point, but this was the groundbreaking publication which suggested, based on the research, that there was something in the order of 44 to like 79, 80,000 preventable deaths due to medical error a year in the United States. And that they likened it to a metaphor of a 747 plane crashing every day, and said, obviously, if that were happening, that would be completely unacceptable And we would, go to great lengths to prevent that from continuing. So the concern was that this level of medical error has been hidden. And I think there are, lots of reasons that was true. Practitioners who made errors were often shamed and blamed, encouraged not to talk about it because of legal ramifications. And the culture began to shift with the publication of To Err is Human. Lucian Leap was a pediatric surgeon at Johns Hopkins, and shortly after the publication of To Err is Human, he was testifying to US Congress. And one of the statements that he made is that the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. So again, this desire to bring mistakes out of the background and into the foreground so that we could begin to learn what it is that's causing the mistakes and prevent the errors from happening again in the future. As recently as last year, the publication from the Office of the Inspector General in a retrospective chart review found that half of the harm events that occurred to patients in the population that they were looking at were not found or discovered or addressed during the course of the patient's stay. So the through line through these publications that I think is really critical is that we're still in the process of bringing medical error, the harm to patients, into the light of day so that we can learn from them and actually prevent them from happening again in the future. We've made substantial progress, but there is still quite a ways to go. So through my career in healthcare, really since 1999 and forward, I've experienced healthcare generally asking some pretty fundamental questions like, what is blameworthy behavior? How can we move beyond shaming and blaming the people who make an error, and it's what we might call an honest mistake, so that the errors are hidden and not addressed? And why is it that caregivers are not reporting safety events? What's the disincentive for them to speak up and help learn and prevent? And what is the cultural change that's needed in order to increase reporting and prevent harm? And how do we balance the accountability between individuals and organizations? So all of these questions, I think, have been current through healthcare for the last 30 years. And most often, the answer has to do with culture, right? So it's not accidental, I don't think, that just culture has begun to promulgate across the healthcare as an industry. So James Reason was the psychologist in England who spent his career studying how errors happen. He died last year, but he was really instrumental in the field of safety science, looking not only in healthcare, but other high-risk industries as well. So nuclear industry, aviation, the military, and so on. But he spent a lot of time thinking about safety in healthcare as well. I listed some of his writings. One, probably the most accessible one, is the book A Life in Air, From Little Slips to Big Disasters. It's kind of his memoir. It's only about 150 pages long, and it's very anecdotal. But he's humble enough to include in his writing not only his theory of how errors happen, but acknowledge other theorists as well, and really hold them up. So the whole field of safety science is only 30, 40 years old and still continuing to evolve. But it was Reason who coined the term just culture, and Reason who created the first algorithm for applying just culture in a situation, and it has taken off. So the framework for a just culture, I think, has to do with, from Reason's point of view, shared accountability, building transparency and psychological safety, and how we learn from errors. This is a diagram that Reasons had to understand how people make mistakes, how people make errors. This is, early in his career, but unsafe acts could be either unintended or intended. And that top portion, an unintended action could be just a slip or a lapse. It's a lapse of memory in the moment, or a slip of trying to perform something and not doing it correctly, or intending to do something but applying the wrong rule or situation, making a mistake about understanding what is needed, or intentionally disregarding risk and violating the rule. So it's helpful to understand this framework from the psychologist when we then move into understanding how it's being applied across healthcare with the algorithms. The diagram on the right, the Swiss cheese model, is probably one of the most recognizable understandings of error in healthcare. It's interesting, Reasons adapted that Swiss cheese model a number of times through his writing. So it's not like there was one Swiss cheese model. He applied it in several situations, but universal to it is at the sharp end of the stick, as you would call it, where the care is meeting the patient in essence. It's most often an active error that's occurred because somebody made a slip or a mistake or chose to do something apart from the way the work was designed to be done. But all of that is based on the defenses that are in place in the organizations that we build not being 100% reliable. And when the unreliable portions of those defenses represented by the holes in the Swiss cheese line up, it allows an error to travel all the way through our normal defenses and reach the patient, all of which come from what he termed the latent conditions. So think of the policies and procedures, the culture, the use of procurement practices, maintenance practices, all of those things that we don't really think about on a day-to-day basis, but inform how we make decisions in actually delivering care in the moment. It's those latent conditions that are not 100% reliable that ultimately lead to somebody causing some harm. The diagram on the left is another way of understanding how there are two components to this. The person approach, which is historically where medicine had been. It's if there was an error, you blame the practitioner, and they're the problem, versus a more systemic approach, which is trying to understand what are those latent systems, those defenses that we have in place, barriers to errors occurring, the safeguards that we built in, the redundancies and so on. How did those fail in this instance that allowed that error to travel through and ultimately reach the patient? So this is an example of the Just Culture algorithm. This one happens to be taken from it's been published by Healthcare Performance Improvement, which is now a part of the Press-Ganey organization. Craig Clapper is the engineer who really was instrumental in promulgating this. This is a one-page algorithm, and I think the one that's probably used most commonly, at least in my experience across the United States. And I know it's difficult to read, but it really is a guide to help somebody who's evaluating how an error occurred walk through a series of questions to understand, was the error a result of some incapacitation on the part of the person performing the procedure? Was it a human error, meaning slip or lapse, a mistake? Was there at-risk behavior, meaning we began to drift from the normal procedure? Or was it truly reckless that there were known risks and somebody decided to move forward despite those risks? Or, and it's not an either or, it can be an and, where their system induced portions of this, where there are ways in which the system vulnerabilities, lack of 100% reliability, contributed to the circumstances. So this is meant to be a decision guide, primarily used, I think, in the relationship between management and people performing the work. But it's also a way to think through what is the kind of error that occurred or the sources of error if we're going to learn and move forward with prevention. So the algorithm in Just Culture, I believe, was really spread across U.S. healthcare by two sources. One, David Marks, who was a student of James Reason. Marks is an engineer, and he built the Just Culture company, which was very prolific in spreading a Just Culture approach across healthcare, had trainings, they did certification for people in Just Culture. And Marx turned the one-page algorithm actually into 5 algorithms based on the duty that somebody who's delivering care should be following in any particular circumstance. So you can see the legal aspect coming into it from Mark's point of view. The Just Culture Company is now a part of the ECRI Institute, for those of you who may know about ECRI Institute. The other person is Craig Clapper. The publication of Zero Harm was several years ago, probably 5-6 years ago, including the Just Culture algorithm and a chapter on the Just Culture. And, you know, Clapper was pretty instrumental through his company, Healthcare Performance Improvement, in also spreading the ideas about Just Culture. So I want to credit them as being sources in the United States. So from my perspective, the value of a Just Culture framework or a Just Culture approach in thinking through errors is that it can support the building of psychological safety. And psychological safety is important because if people don't speak up, we won't hear about the errors, they'll be hidden, and the harm will occur and we won't even know it, discover it until, you know, down the line. So the more people feel safe in speaking up, either for a hazardous condition or an error that has occurred, the more we'll have the opportunity to support them and to correct the situation. It's also a way, in my view, of management and workers having some mutual accountability. So, and I think this was a really important point when I was in an organization and helping to implement a Just Culture approach. It's not just about the accountability of the individual delivering patient care. I believe it's also about the accountability of the organization to those caregivers. It's a two-way accountability, both with the interests of the patient in mind. And it's a way of helping to balance both persons and systems approaches. And ultimately, the goal is, you know, reducing human errors, at-risk behavior, and the system errors, system-induced errors. So by learning more, preventing harm in the future, we will increase the value of the Just Culture. It's complicated, though. Healthcare is complex, as you well know. There's Carl Weick had a good chapter in a book on the current state of safety science research, and talks about the socio-technical aspect of healthcare, meaning that technical knowledge is necessary, and this is, I think, what we've traditionally thought of. It's the practitioner's skill, it's the surgeon's skill in performing the surgery that is really necessary. And technical knowledge is certainly valuable. It's those procedures, it's how we understand and use devices, it's the science that underlies healthcare and medicine, it's my individual skills as a practitioner, and the organizational norms. Think of, you know, the peer review process and what we support and that sort of thing. But there are also social knowledge aspects that are critical. How we treat one another, how we communicate, the sense of trust and honesty that's in the organization, the psychological safety, as we were just talking about. Those are a part of the organizational culture, which are critical for creating the accountability structure for a Just Culture. And where it comes into play then is as we begin to design systems. So this, may look familiar to many of you who have, worked on a floor in healthcare. There are 3 different gases in the wall, and there are 3 different types of connectors and 3 different colored hoses. Kind of a simple design, but to help support people to do the right thing. And that gets into then human factors. How do we design our systems to help prevent errors from occurring? The challenge is what happens in the crazy environments in which we really work. So this is probably not every ICU bed, but they're certainly out there. And it's not only intensive care. Every area of healthcare is going to have its level of complexity and challenge to think about how do we mitigate the risks in the way that we design our systems, as well as the way that we support the people who are working in those systems to prevent the errors, or if an error occurs, to support them in speaking up, sharing it so that we can prevent it from going forward. We won't go deep into this, but through some personal communication with Bob Latino, who was kind of a mentor around root cause analysis and reliability engineering, there are 2 schools that underlie human factors. Don Norman is the writer that's most responsible probably for human-centered design. It's how you design things that work for people. And in his book, he's got the picture of what he calls the masochist coffee pot as a silly example of how not to do design to work with people. But there's also Sidney Decker and his colleague Todd Conklin are prolific writers who have addressed human performance and just culture. And human performance is really looking at it's the interaction between human beings and the environment. So it's not just the design of the environment, but it's the way they interact. And the ECRI Institute has long had a lab. It's a patient safety organization that's federally qualified, and they've had a lab for years that is instrumental in doing research into how the design of equipment, for example, either supports or increases risks or mitigates risks. And they do investigations after errors have occurred to try to figure out what's the interaction between the caregiver and the piece of equipment and understanding that. So those 2 schools of thought are underlying. Oh, and I put the picture of the airplane because Sidney Decker's a pilot, so a lot of his references have to do with the human design of the cockpit, which was probably one of the first places where human design really came to the forefront. Now, I've spent 25 years thinking about and doing and teaching root cause analysis. So thinking about how all of this in a just culture applies to the process of unpacking how did an error occur, it really does get to trying to understand with some empathy how human beings made mistakes, either did something they shouldn't have done or didn't do something they should have, errors of omission or commission, that were the result of the systems in which they were operating. So getting down to those latent root levels, as James Reason was talking about. And the root cause analysis, in my view, is really our way of methodically using deductive reasoning to get back to the point of understanding how did those latent systems lead to decisional errors that led to physical harm. So back to the algorithm for a moment. Using the algorithm to prevent errors, we touched briefly on the 5 types of errors or sources of error. Incapacitation, I think, may often be thought of as a substance abuse, result, but it can be other things. I once had a nurse who became incapacitated while at work, and it turned out that she had a brain tumor. So incapacitation certainly can involve substance abuse and diversion, but it's more than that. And I don't want to gloss over that as, something that shouldn't be considered, although it's probably rare. When people make mistakes that are honest mistakes, a slip or a lapse, what the just culture approach and framework suggests is that we ought to console them. You know, they were not intending for harm to happen. In fact, they were quite the opposite. They were trying to do their best, and despite that, something, harmful happened. So console them and understand what it was that led to that error, and then learn from that and prevent it. At-risk behavior is where some drift from the work as designed has come in, and that's pretty common. For example, if I'm driving on the freeway and the speed limit is 65, and I'm creeping up to 68 miles an hour and I don't get a ticket, or if I'm at 70 and the state patrol is there and doesn't pull me over, suddenly 70 has become my sort of outer limit, and then it creeps up. The normalization of deviance was a term that was coined to understand the Challenger disaster by a sociologist. And it applies to that idea about at-risk behaviors become more normalized the more they're practiced, and when nothing bad has happened. So it becomes the kind of the new norm, the new standard. So we want to coach those situations and get back to the practices that we have designed in order to deliver the safe care. And then finally, reckless, when somebody has intentionally, deviated from the safe process, knowing the risks, moved forward anyway, that's appropriate time to consider and apply discipline. And in all of those situations, we can look at how the systems may have underlined or supported the results. Just a quick update from the National Health Service in the United Kingdom. James Reason had published the algorithm, and they were using it on a widespread basis through the National Health Service for years and years. And just recently, they have stopped using the algorithm and moved to a set of questions that's in a more narrative form. And I wish I knew more about the background about why that transition came up. So that's an area I need to spend a little bit more time. But I did want to acknowledge that the algorithm itself is not the be all and end all. There is at least some movement toward rethinking its use. But some points for us to consider, and this is where the conversation can come in. I believe that there's been a misconception around just culture as it's a no blame approach. And I don't believe that that's accurate. And I'm not sure how that sort of urban legend got started. But I hear it. I have heard it. And so, from my point of view, the just culture is an accountability structure. It's an accountability system. And as I suggested earlier, there's accountability both for the person performing whatever procedure, as well as for the organization. So it's an accountability structure. It's not a no blame structure. In fact, discipline can happen. Another idea is about outcome versus process driving the decisions. To go back to the example of speeding, if I'm driving over the speed limit and I'm drifting up, do we not worry about that until there's actually an accident that happens? Or do we think about the law is the law, and I'm actually guilty for speeding and would, if pulled over, acknowledge that and accept the consequences? Maybe a better example is that with reckless behavior, the example of drunk driving, do we punish drunk drivers only when the accident has killed somebody? Or do we punish drunk drivers when they've gotten behind the wheel and have been driving intoxicated, even though nobody got hurt as a result, fortunately? So from my point of view, I think that the just culture framework really looks at how we have deviated from processes or how we've chosen to behave. So it's based on the behaviors more than the outcome. You know, historically in healthcare, we've often waited until the bad thing happens to then go back and look at, you know, what happened or what led to that. But the just culture, I think, as a way of supporting speaking up, identifying errors or risks and learning from them, is more interested in the processes, regardless of whether there was harm that actually occurred. So yes, we care about harm, but from the just culture perspective, we're also looking at all of those situations in which harm did not result, but could have. The other,
Could I add something to that?
yes.
Thank you. So in looking at just culture, just in my perspective of like working in different organizations in the past, is there's a part that I wish was a bit more focused on, which is where it touched me the most, which is the rewarded vulnerability with psychological safety. Because that's where the blame truly comes, but it doesn't come as a blame. It comes more of, you spoke up about this. We appreciate that. Now we need to look into this and see how this process could be better. Or if it's a human error, how can we change the process itself for your department, the people that you work with? Or is it an equipment error that we need to fix ourselves? And I think that piece gets cut off a lot, because I've talked to like new nurses too, is once they feel safe with that psychological safety, they're actually able to speak up about things that are not working well and errors that they see versus, I don't want to speak up because someone's going to blame me for it. And it's really good to see, like, hopefully more organization focus on that piece of the psychological safety to encourage people to speak up a lot more. Because I think that would do a lot for the whole system to really push like a just culture, and opposed to just pushing the surface, but not kind of getting deeper to where it actually touches the humans and the staff that they work with.
That's very well said, and I agree completely. Perhaps part of the misunderstanding of just culture is that it's used as a disciplinary tool only when something has gone wrong, as opposed to understanding how it's intended to support a whole culture of an organization in promoting psychological safety and speaking up and learning to prevent harm from happening. Yeah. It related to that is the idea that an algorithm is a substitute for the judgment of leaders, and it's not. It's not a black box that you just feed data into and the right answer spits out at the other end. It's a tool to help guide the process, but we can't abandon what are the fundamentals of good management just because there is an algorithm, or use the algorithm in a way that actually contradicts a just culture approach. You know, part of the use of the algorithm is it has to be applied evenly and fairly across the organization. One of the things that really bothers me when I hear news reports about errors that occur is the attribution to it was human error, and the implication is that we stop looking. So it was the person, they did something they shouldn't have done, and that's the end of the story. It's not a coincidence that at the bottom of, I think, every part of the algorithm, there is the prompt to ask the question, were there systems issues, just what you were getting at? Are there system issues that we should be addressing and looking at to prevent this situation from occurring again? So if we stop at human error, we miss that opportunity, and we really need to understand the interplay between the human beings who are doing the work and the whole organization that supports it. Another one, and these are in kind of random order, no particular order, but another one is the idea, so if somebody makes the same error, that's a human error, but they've made it 3 or 4 or 5 times, does that mean, we can't do anything about it? And from my perspective, the answer is no. You can do something about it. Perhaps that's not the right position for that person to be in, or, think through what does the work need to be redesigned? Do they need to be coached and supported to find alternate work? Repetitive errors, I think, does not mean people just get repeated passes on what they're doing. It's a signal that there's something going on with the behavior that needs to be attended to. So I included in the slides a few resources if you wanted to know more. And I think that's the information I had to share.
Who's got questions or comments? Who wants to go first?
Oh, we have it.
Not necessarily a question, but I raised my hand as lightly hearing of this, but touched on so many aspects of the job that I do every day. And I remember when I first started into the industry as a director of long-term care, there was a med tech that within the first week came to my office crying upset, and she was like, "This is my third error. I'm going to be fired." And I, not even knowing the industry, because I came from the hospital, said, "What do you mean? Is there like a policy in place that, you're going to be fired for that?" It also is, I always start off any error with, I appreciate their honesty because they're afraid to come to you anyway. And then my last point in this, which this like really rang to me in just every day what I do. Is it a system error, but is it also human error? And can it be both? And how do we fix those things? Sometimes even just a human error has brought up a part where there has been a system breakdown too. And sometimes you don't even know that until you really do a deep dive into what was that error to begin with. So I also thank you for this presentation. I thought it was excellent and really brought a lot home to me.
Thank you once again. There was a strange aspect that I thought would be on here, but wasn't, and I can kind of make up things in my mind, is the concept of a lot of organizations, I think about 2-3 years ago, were pushing to go towards high reliability organization to include just culture, but with the finance and everything, everyone's slowly pulling back and they're starting to see the effect of all this in the system with restructuring and finance kind of going back. Have you guys ever kind of done the just culture lecture with high reliability organizations?
So Craig Clapper in the healthcare performance improvement is, one of the big proponents of HRO, high reliability organizations. And Carl Weick, who I quoted earlier, I think wrote the book on really about high reliability. And my experience has been that just culture is one of the foundational pieces for high reliability. If you don't have psychological safety or that sort of relationship structure in place, then it's hard to design reliable systems where the people do the work as designed. One of the sort of more modern takes on safety science is looking at how there is this discrepancy between the work that is designed and the work is actually done, performed, and trying to close that gap as much as possible. And that's where reliability comes in, right? So yes, just culture and high reliability are very much wed. I retired in 2022, so I hear about healthcare, being more concerned around finances at this point and reorganizations due to that. It's totally anecdotal, it's what I read. But yeah, that does seem to be the climate we're in.
Thank you.
One thing that, well, and I feel like this is part of what you're talking about. You might have mentioned it once, but like I now teach full time, but when I worked in the hospital, there was also this big push around near misses. So really, because I feel like it's not even just reporting when something goes wrong, but it's when those near misses happen. And I had some experiences like that where something came from pharmacy and it was the wrong medication, but it had the same label and color and everything. And they had just made a change. And so the pharmacist didn't catch it. But it was like, I was like, oh my gosh. And so then, sent it. But then the company actually ended up changing it because it caused like so many issues. And like that piece of, somebody saying, well, are you going to get them in trouble? And it's like, No. This is like a systems change issue. So I really appreciate that. And then I was also just going to say, interprofessional working around these things, I think, is really important too, because I feel like in nursing, like sometimes there's that blame game that can happen within the professions. Well, so and so should have done their job, and then I wouldn't have had this thing happen. And so we like the IPE session that we had just last month. The students actually looked at multiple, like we're looking at just culture and multiple, like doing root cause analysis around some things. And I had not seen that before. And I was like, this is beautiful, because this is how they need to be practicing, out there in the real world is as a team and really analyzing each other's roles. So anyways, I appreciate you coming and talking about this, because in my 26 years of nursing practice, I've seen a major shift away from that punitive. But I know that it still occurs in some places. So thank you.
Thanks.
Anybody else? I'm going to hold my other thoughts, so someone else can go.
No, go for it. I have some things that I want to share and ask too, but go for it.
Okay, I was just going to follow up with what our board member just said, to realize that we're like at the last line of defense as nursing staff, at the end of the road, and some of those things could be punitive at some point in time. And a lot of organizations taking a word misses away. They're like safety event or good catch, something to put it in a more positive light for staff to be able to kind of get around it.
Sydney Decker, who I cited a little bit ago, suggests using the term good catch rather than near miss or close call, just because of that sort of change of perspective. Yeah.
But I wonder, if you do that, do we not take it seriously as a near miss and then try to prevent it from happening in the future? I don't know how that works, but when we think of near misses, it's a mistake or it's a near fall. Like, don't just look at falls, look at near falls to know the risk. So I wonder, that's a whole cascade of, do we then take it seriously? Are they doing that when they
I think they just changed the title. It goes through the same process. And I think the title changes to not put that negative impact. Like if I'm going to submit a near miss and I'm like, oh boy, let me be mindful what I say, versus a good catch.
I love
something
that.
really good. So here's what happened. And people are more likely to like put more details if it's like a good catch.
We used a stratification of, red, orange, yellow, white events. Red being the most serious, usually harm has occurred, so white. And from my perspective, it's the orange, where that's the gold. So the harm hasn't happened, but it's a high-risk situation. That's where, if we devote our energy to improving the systems and learning, the biggest bang for the buck is right there.
Can I jump in for a sec? I just wanted to call out, kind of ties back to your comments earlier, Nikki, about the culture of safety and how absolutely important that is. That one of the challenges I've seen with organizations who are either really focusing on implementing just culture culturally, or implementing new software potentially that supports event reporting, that success often looks like an increase in event. Success looks like benchmarks actually are going the wrong direction, but really it's an indicator that that culture of safety is in place and growing. And I think it's really helpful to have that language kind of like pre-packaged for especially the frontline leaders who maybe are really focused on achieving certain goals that maybe are even financially tied in for an individual or organization. That's expected, and that is actually an indicator of success.
So, members of the board, the reason why, so ultimately Laura Van Kira had done one of our nurse investigators had done a lot of work in patient safety and introduced me to David, and we had a conversation and invited him here to present to you all, because and explain to him how we boards of nursing across the nation, we use our board action pathway as a tool. And now, have kind of created our own tool to really look at, the actions of a nurse and how they may or may not constitute a violation of standards of care. And we know hospitals are using this, and so hence wanted that perspective to understand how they are using reporting and accountability of reporting errors. But one of the real things that I was hoping you can maybe speak a little bit more about, as the board discusses, we often talk about risk versus outcome, and this is what you and I had a little conversation about. Because an outcome can be, something that sounds really a lot of harm, but would another nurse in the same exact situation have had the same outcome because of stuff happening, because of mitigating factors, because of systems issue? But sometimes I do think that some of the tools we use, it has us looking at outcome versus risk. So I don't know if you want to speak to that at all. I know you mentioned when we were talking, your work in hospitals and presenting to boards, but I know that's real vague, but just we have time to maybe add that context in for them, since that is something that we wrestle with a lot in our executive sessions.
So the framework of a just culture accountability system, I think, is really based on understanding behaviors, and regardless of the outcome, which is a real shift within the way that we have evaluated harm in healthcare. So that's part of the cultural transition, I think, that has to occur. And it's related to psychological safety. We're not going to get there if we don't promote the ability to speak up and then look into, what were the behaviors and what were the causes of those behaviors, regardless of the outcome. We're probably in a transitional period, would be my sense of that. There's still vestiges of, well, if nothing bad happened, then, we dodged a bullet, let's move on, kind of thing. Versus, well, nothing bad happened, but the behavior could have resulted in harm or serious harm. So let's pay attention to that and try to understand what occurred in this situation that we could apply, more broadly. My experience was that the more caregivers at the bedside, and broader than that, so environmental services, food staff, all caregivers, the more that they feel like they can alert the organization to a potential harm, the more opportunity we have to correct problems, the better off we're going to be. We saw a significant reduction of harm events as we saw the increase in the ability for people to speak up and just talk about, alert what was going on that they were concerned about. So in a situation where somebody can say, I've got a safety concern, which may or may not pan out into a harm event, that supports this idea of, okay, let's be accountable together to figuring out what is the risk and how can we prevent the harm from happening. So I do think that that's the approach we need to be taking.
It can happen the next patient, the next caregiver.
Yeah, that's right.
Yeah, and I think, at the national level of boards of nursing and probably other regulatory boards, it is that conversation about just culture, about what our, like I said, not just looking at harm, but risk. And I think historically, regulatory boards have always been seen as punitive, but how do we really look at all the other pieces that can prevent it?
It's one of the areas where I think in healthcare, we have the opportunity to learn from aviation and some of the other high-risk organizations that deal with very complex situations that are more attuned to briefings, debriefings, identifying risks, identifying potential harm because the stakes are so high. We're making progress, and I think there's a way for us to go.
Thank you. And we learned from them to decrease infections with PICC line, so why not everything else?
It's the Swiss cheese model. Any other questions or comment?
Thank you very much. Appreciate your time and being here.
Thank you so much for this. Well, we still have time before our public forum, which is at 1 o'clock. So why don't we take a break? We'll take a break till.
Yeah, take a break and then we'll have our 1 PM forum, public forum, open it up for that, and then we'll have Oregon Wellness Program before we leave.
Just be back like 5 minutes before. Should be fine. Thanks.
ownership of that.
Yes. Phil, are we good? Hey.
Recording in progress.
It is now 1:00, and we're going to move into the public forum. Welcome and thank you for joining for the public meeting today to share public comments. It is February 19, 2026. Public forum will last from 1:00 to 1:30 p.m. and each person is allotted 5 minutes. Open forum is a time for members of the public to make general observations or present items of general interest. Open forum is not an opportunity to make requests to the board or to discuss matters currently under investigation or review by the board. The board will not deliberate on any issues or requests during the open forum. The board president has the authority to stop individual comments if the board president determines that the comment goes beyond this directive or is necessary for efficient and orderly conduct in the meeting. Looks like we have 3 people signed up, 1 in person right now. We're going to start off with Sunny Ramos. If you want to come, hi, you can come up and sit right here. Take your time. Okay. Brandy's going to turn on the mic. So this goes for 5 minutes and we do not make comments at all, but we're here to listen. Let me know when you're ready and your time will start.
Okay, I'm ready. Thank you.
All right.
Esteemed members of the Oregon Board of Nursing, my name is Sunny. I'm addressing you today as a proud lifelong Oregonian, and I am also somebody who grew up as a foster child under the care of Oregon Department of Human Services. Unfortunately, in that time, I did learn firsthand that an agency that was designated to protect those most vulnerable often turned a blind eye to misconduct and protected those that did harm. And I believe that it is crucial to hold each other accountable. That is why I myself became a foster parent, the same organization I grew up in. I believe we can do better, and I believe we must do better for each other. I'm here to ask you to protect our community and revoke the license of Kamisha Lynn Hart. She has repeatedly made public statements that are hateful and bigoted remarks against Jewish people in particular. She has shown she cannot be trusted to treat Jewish patients, and there is never a place for hate in healthcare. These are Kamisha's own words regarding the kidnapping of Shiri Beavis, a Jewish mother, and her small children, Kafir and Ariel. She was fair game. Hamas let her take her children out of pity. They should be thankful they weren't returned in blue body bags and zip ties. It should be noted last year that their bodies were indeed returned. When later confronted online about her anti-Semitism, Kamisha replied to a Jewish person, "I would never treat you anyway. I would refuse because I am not a vet and I do not treat dogs." She reaffirmed these statements by telling yet another Jew, "I would refuse to treat you. I don't take care of animals, dogs, rats, vermin of any kind." When given the chance to do better and recant, Kamisha instead doubled down. These are the words Kamisha felt proud and comfortable enough to state publicly. Again, she said, "I would never treat you," saying this directly to a Jew. Kamisha has made it clear to all of us that she will refuse to provide medical treatment to Jewish patients simply because they are Jews. And this flies in the face of Oregon law, namely Senate Bill 567. SB 567 clarifies that it is unlawful for any individual licensed or certified by a health professional regulatory board to discriminate on the basis of a protected class. This is including, but not limited to, denying medical treatment to that patient. It is an essential part of nursing and providing medical care that we ensure that patients of all races, religions, and ethnicities are treated with dignity. This does include Jewish patients. Nurses have a legal obligation to carry out their duties ethically and without prejudice. Kamisha has told us in her own words that she has every intention of behaving in a profoundly unethical and unlawful way. Any human who makes such hateful and anti-Semitic remarks, anyone who boasts that they will deny Jews medical treatment solely on their ethnicity and religion, has no business holding the title of registered nurse. Anti-Semitism is unfortunately on the rise, and Jews across America have been facing threats, intimidation, and violence. If we communicate that targeting Jews or any protected class is an acceptable practice in the medical field, it will be an unfortunate and unnecessary stain on Oregon's history. OHSU terminated Kamisha's employment, and that sent a clear message that senseless hatred, bigotry is not welcome within their institution. However, when the Oregon State Board of Nursing made the active decision to renew Kamisha's license unencumbered, that sent the opposite message. The buck stops here, and it is up to the Oregon State Board of Nursing alone to honor their responsibility to protect the public interest and promote equitable healthcare. If Kamisha Hart's license remains intact, the Oregon State Board of Nursing will be rewarding illegal discrimination against a protected class of people. This will lead to harmful consequences for the health and well-being of Jewish patients. The question now is, will you allow Oregon to become a safe haven for medical personnel that delights in the death and suffering of Jews? Or will you protect those that are most vulnerable, those seeking ethical and equitable care from licensed healthcare professionals? I thank you for your time.
Thank you. And looks like we have Brian Fulfrost
Yeah.
online.
That's me.
All right, are you ready, Brian?
Yeah.
All right.
Thank you for letting me talk today. I'm not going to be nearly as articulate as that a previous speaker, but I'm here to express my huge disappointment, my anger, my disgust, and my huge concern that the board has made a decision not to discipline Kamisha Hart for her bigoted, hateful, violent comments that on social media, which I wasn't going to mention because I'm not going to be a conduit for that hate. But the previous speaker said, repeated a lot of the things, so I don't have any need to repeat them. And what I believe that the board has done by not disciplining or in any way Kamisha Hart is set up a discriminatory health care system for Jewish Oregonians. I am a Jewish Oregonian. I'm very concerned that, as in past times, the Jewish community is not being protected. And now we have decisions that allow people like her to practice nursing in the state of Oregon, even though she's openly expressed her hateful and discriminatory and bigoted views. I would posit that if she expressed those views with regards to any other protected class, there would have been some discipline. And I understand and have heard the reasonings behind the board's decision, and obviously I don't agree with them. I think it falls well within the measures of what is or isn't professional conduct. There are other examples of nurses being disciplined or having their license suspended for similar behavior in the UK, in British Columbia, in an ongoing case in Kansas, in another case in Florida. And her behavior clearly states her discriminatory intent, let alone her hate and violent rhetoric. So I know I'm not supposed to suggest anything, so I won't do that. And I'm not trying to suggest, go into that. I was trying to be positive by creating suggestions, but I won't do that because it was said that we shouldn't do that. But I'm telling you from my own personal experience that as a patient in Oregon, I just had hernia surgery. So every time I go into a healthcare setting, now I have to know, is there a bigot in the hospital? Is there somebody have to be concerned that they're going to be discriminatory because I'm wearing a Magen David across my neck? No group should have to face that discrimination. None. And I do believe that it's well within the rubric of unprofessional conduct. If there is anything that falls within the rubric of unprofessional conduct, to me, her social media posts and beliefs fall into that rubric. I implore you to do better, to protect not only the Jewish community, but every community that you can from discriminatory behavior. Thank you for letting me talk. I'm sorry it wasn't as articulate as the previous speaker, and thank you again.
Thank you very much. And do we have Karen Anderson online?
It seems like the third person has not joined us.
We can give him a few minutes since we still have a bit of time. Or maybe I should ask, are you guys coming together or separately? Okay, thank you. We have to stick with the timing of when you make your speech, unfortunately. Thank you. I think we can give like 2 more minutes, hopefully, till 1:15.
Ultimately, we'll leave the virtual room open till 1:30, and then Oregon Wellness Program will, or anybody who comes in from the street for the next 15 minutes, and then Oregon Wellness Program will present.
Sounds like a plan.
Okay.
Do we have anybody online? Just confirming. Thank you. All right, we're at time. Do we have our presenter online? Huh? So public forum is now over and we'll move on to our next agenda. We have Dr. Hudson online. Hello.
Yes, hi, hello.
And we'll give you the floor to introduce yourself and what you have for us today.
Okay, great. Hi, everyone. My name is Mandy Hudson. I am a psychiatrist by day in my working life, and then also the chair of the Oregon Wellness Program Executive Committee. And so I'm here today to talk to you a bit about OWP. Let's see, thank you. So a little bit about our mission. OWP, the Oregon Wellness Program's mission is to promote wellness for healthcare professions in Oregon through coordinated counseling services, education, and research. And really the goal is to be able to provide immediate access to mental health services for all of Oregon's or many of Oregon's healthcare workers. We've served over 142,000 licensees, and that includes advanced practice nurses, RNs, CNAs, nurse practitioners, physicians, physician assistants or associates, podiatrists, acupuncturists, dentists, dental hygienists, dental therapists, and I believe what's missing from that list is also respiratory therapists. Is that right, Eden? No. Okay, just kidding. I lied about that. But we're serving a big chunk of the healthcare workforce. Next slide. Our vision is that we're by and for healthcare professionals. So all of the licensed mental health clinicians who see our licensees have specific experience in providing mental health care to healthcare professionals. And so they really have an understanding of the unique experiences of healthcare professionals. We also are committed to confidentiality, and this is a voluntary service. So nobody's being mandated to come see a OWP provider. It's confidential and it's voluntary. And then complementary, meaning that we hope to not have, we don't charge. We'll get a little bit more into that in a minute, but that it's complimentary, it's free, that it's timely and flexible. I know, if any of you have tried to seek out mental health care in the state or have patients who have or family and friends, the time that the wait lists can be really onerous. And so we have a commitment to get people in basically immediately. The vision is also to just help address the burnout epidemic. Healthcare workers, we face a very high rate of burnout. The funding follows the client, and we're also trying to just reduce all of the barriers statewide. Next slide. So just an overview of OWP. It is a project of the Foundation for Medical Excellence, otherwise known as TIFME, which acts as our administrative hub. It's guided by the executive committee, and our executive committee is made up of various healthcare professionals, as well as some folks from the different licensing boards, and we meet monthly and help to guide the program. This is a statewide effort providing self-referred, highly confidential, urgent mental health services to active clinical providers. So it's not an emergency service. We are not on call for emergency care, but it is urgent and we get people in really quickly. We don't specifically handle substance abuse disorders, and we don't handle clinical competence concerns. So again, we're not, a place where people would be mandated to go get counseling or something. Next slide. We have 17 different healthcare organizations who have had their employees get treatment through OWP. And so, you can see the list there covering a lot of different entities in the state, including folks who are, in their own private practices and that kind of thing. So growth, this is important to talk about. So prior to, Eden, help me out with the exact date that we reduced benefits.
It was mid-2024, so July, essentially.
July of 2024. So prior to July of 2024, we offered 8 free sessions per client per year. In 2024, you can see the rate of use there went way up. And we didn't have an equivalent increase in funding. And so what we realized that if we continued at that rate of use with the funding that we had available, we would go bankrupt and not have a program anymore. So we had to make some really, really tough decisions. That decision was that we needed to reduce the number of free sessions available to licensees. The magic number we kind of landed on was 3 sessions. So each licensee gets 3 free sessions. Now they can absolutely go on to use their insurance or cash pay or, however, if they want to continue seeing the therapist that they are set up with. So it doesn't mean that they can't continue getting care. OWP just can't fund more than that right now. And it's important to realize that although the overall utilization sessions have declined due to this need to restrict the number of sessions, the new client rate has remained consistent. So that means that we have as many new clients coming into the program as we did before. It's just that we're only able to pay for those first 3 sessions rather than 8 sessions per year that we were previously doing. And I'll also point out on this slide, nurses became eligible to participate in OWP in June of 2022. And that's, kind of where you see this increase in usage. Does that make sense that our new people entering the program has remained the same, but because we had to limit it, the number of sessions has gone down? Okay. This is our usage by licensing board. So you can see that the Oregon State Board of Nursing uses 49%. The Oregon Medical Board is using 49%, and then the Oregon Board of Dentistry is using 2%. These are our 2025 numbers. So the licensed by the medical board, we had 90 clients for a total of 209 sessions. The nursing board, we had 89 clients for a total of 214 sessions. And then the dental board, 3 clients for 8 sessions. So those were our, again, 2025 numbers. Again, 89 nurse clients and 214 sessions. These are some of our nurse client snapshots. So you can see a majority female. Age range is kind of, split pretty evenly there, and probably proportional to ages of practicing nurses. The different license types, majority RN, a little bit of CNA, APRN, and LPN. And then practice area type, mostly urban, a little bit rural, a little bit semi-urban, that in between part, and then a very little bit remote. We just wanted to put in some testimonials from some of the folks that we work with. I won't read them all, but I'll read a couple. And these are our providers. So these are from the licensed therapists who are providing services to the healthcare workers. Beth Westbrook says, I've seen nurses through the OWP that have benefited greatly from easy access to treatment, quick evaluation, and referral to ongoing help where needed. The work has been life-saving, career-enhancing, and critical as nurses have faced delayed post-traumatic stress problems and increasing work demands. Lara Kosak mentioned the numerous nurses I have served over the last year have been unanimous in both their need for support and in their deep gratitude for the recognition of that need through OWP. They have felt seen in their importance and in their needs with the support of OWP. Many have reported a return to greater contentment at work and in their professional lives after accessing the benefit. And again, I just want to reiterate that all of our providers, all of our therapists do have that specialty experience working with licensed healthcare professionals, because as you all know, we face different demands than some of the general population. And it's really important that I think they understand what we as healthcare professionals face. This is a client testimonial. I have been an emergency room nurse for 15 years. Throughout that time, I've experienced hardship, anxiety, depression, and uneasiness regarding my job. Daily, I am met with pressures of working fast, efficient, and precise. I'm expected to be kind and patient to those who do not share those qualities. I'm expected to be an emotional chameleon during that 12-hour shift. One day I have to care for an intoxicated individual that is verbally and physically abusive, then care for a sick 3-year-old without skipping a beat, going from a hard, scary, or sad situation to being kind and gentle. OWP Services has provided me with a healthy outlet to work through the hardships of being an ER nurse, deal with my personal life in a healthy manner, and come to work with a better outlook and understanding. I am a more self-aware person overall, and I know this program has prolonged my longevity as a nurse, but has made me a better one. I have gained coping skills. I have improved my communication skills with patients and coworkers, and I have more self-love. I owe the OWP for providing me with free counseling and making my mind healthier so I can care for others. And this was again, an ER nurse from Silverton. So I just want to talk for a moment about a research project that the OWP was involved with, understanding the well-being of healthcare professionals in Oregon, a pilot study on burnout, childhood trauma, and mental health accessibility. So this was looking at ACEs, the Adverse Childhood Experience Scales. It was a cohort study with surveys that were done at 2 points in time, 8 months apart. And it assessed changes in professional well-being among OWP users and then also non-users. So they measured professional quality of life scale, and this measures compassion satisfaction, fulfillment and satisfaction from helping others, and compassion fatigue. including burnout and secondary traumatic stress. We know that compassion fatigue and compassion satisfaction are two really, really important factors in burnout overall and in all the studies of burnout. It also looked at ACEs, so it measured participants' experiences of childhood trauma, and then it looked at barriers to mental health access. So it gathered qualitative data on the obstacles healthcare professionals face in accessing mental health services. The participant and group included a diverse range of healthcare professionals across Oregon, which provided a comprehensive view of mental health in this workforce. There were 280 completed responses to the survey and 116 follow-up responses. 25% of those were OWP users. The users averaged 8 visits in the last year, so this was before we had to make the change. And on average, users had been using OWP for 26 months, so they had been involved in the program for a couple of years. And then you can see there the breakdown, male, female, the age groups, race, different professions, and years in the profession. So the findings, almost 40% of participants had ACEs scores of 4 or higher, and we know that ACEs scores of 4 or higher are associated with an increased risk in all kinds of health problems. The study found that higher ACE scores correlate with greater burnout and secondary traumatic stress. When participants were asked if they were interested in receiving mental health care, 72% of the whole cohort answered probably yes or definitely yes. OWP users with longer program engagements showed a significant positive correlation with increased compassion satisfaction. And again, there's a strong correlation between compassion satisfaction and burnout. Users of the OWP experienced an average decrease of 3.7 points in burnout scores over time. And that's a statistically significant difference compared to the non-users. Users of the OWP experienced a 2.25 point reduction in secondary traumatic stress and a 1 point increase in compassion satisfaction over time, encouraging trends that reflect improved well-being, though these changes were not statistically significant compared to non-users in this pilot study. All right, understanding some of the barriers to accessing mental health care. So the researchers asked participants about the main barriers they face when seeking mental health support, and key themes emerged. Cost, finance, insurance was mentioned 87 times. Scheduling availability mentioned 66 times, confidentiality 39 times, a good therapist fit was 33 times, and a desire for telehealth was 31 times. Just some key quotes from the study. The cost is the #1 factor. Privacy is critical. I'm afraid my mental health records will be seen by colleagues, so that was really important. And then also consider strategies to improve scheduling availability and reduce wait times. So those were all really important things to the study participants, and that's handy because those are all really important things to OWP and exactly why we do what we do. All right, we're going to just dive into some of the financials of OWP. So this year we're asking from the Oregon State Board of Nursing $250,000, and that funding will go to serve nurses. We're asking the Oregon State Board of Medicine for $125,000, and that would go to anyone licensed by the OBM. And then for dentistry, $40,000. We have some funds that are rolling over from 2025 from the Eastern Oregon CCO, and you can see that number there. And then we also have a grant from Care Oregon, and you can see that number there. And so that's money that would be there to serve all OWP users regardless of license type. So how have Oregon State Board of Nursing funds been used to date? This is 2025 expenses and funding sources. And again, I just want to reiterate that no OSBN funds were used to pay for services for OMB or OBD licensees. So the nursing board funds are used to serve nurses. In 2025, again, we have the 89 nurse clients and 214 individual visits. $43,000 was used for clinical services. $29,000 is for administrative and marketing services. $11,000 was used for research. And so that comes to that $83,000 total there. And again, this is just breaking it down in a different way, a different table of our 2025 expenses. So the three different boards, the license fees that were used, and then the gift uses from that, the grants, the Care Oregon and EOCCO monies. Again, just breaking down the uses and sources of OWF funds for services. We did the nursing board slide 2 slides back, but this is looking at the Oregon Medical Board and the Oregon Board of Dentistry and breaking down that funding as well. So our request for 2026 from the nursing board is to renew the funding effective March 1st, which is coming up real quick, at $250,000. As of the end of 2025, there was a remainder of $147,455 in that account. Oh, and so we're hoping, I think if we can maintain the funding that we have been doing, we'll be able to continue with services where we are. We're also continually lobbying legislation to hopefully get some legislative funding as well. Our ultimate goal would be to go back to the 8 sessions per licensee per year. And we'd love to be able to serve at that level that we were serving previously. But our, most important goal is that we just keep operating again by getting people in really quickly, and at least they'll have the access to care and then they can continue on based on that. So this will allow us to at least do that. And then our hope is in the future, we will get additional funding and be able to go back up to those 8 sessions. And hopefully serve more people. We'd love to be able to do more marketing and more outreach and serve even more folks in the state if we can afford to do so. Okay, that was a lot.
Thank you very much, Dr. Hudson, for that presentation. It was really detailed, and I'm sure everyone on here appreciated it. I had, I think, 2 questions for you. I know you mentioned quite a few times that the goal is to try and get people in really quickly. What is the average wait time?
Yeah, Eden, can you speak to that?
I can sort of speak to that. We have a promise that we'll get people in within 72 hours if they express an urgency. I don't know, because it's the individual providers who get back to them. I don't know what the average wait is, but we do have that commitment to within 72 hours. If they need it, they can see someone.
Thank you. And the other question might be for Dr. Hudson and our executive director. You did show us the map of how many staff, how many licensee you have. You have lots of RNs that you see. Is the funding also to cover both LPNs and CNAs or just RNs? Okay.
Yeah, so it covers, and I'm just pulling that slide back up on my section. It covers RNs, LPNs, CNAs, and APRNs.
Okay, I think maybe like your third to your last slide could just said for nurses, and that might have been the confusion there.
Got it. Okay.
Thank you.
Yep.
I have a question.
Mhm.
You had showed a slide that for the nurses, 43,000 was used for clinical services and another 29,000 for administrative and marketing.
Mhm.
So can you explain what falls into administrative and marketing? Because that seems like a really high expenditure compared to the amount of money actually spent on the clinical services.
Mhm.
Do you want me to speak to that, Mandy?
Sure.
Okay. So the administrative services pay for part of my time, honestly. So half of my FTE is covered by Tiffany, and half of it is covered at a ratio between the OSBN service fees and the OMB. So that's the administration of the program, which is just me at a part-time role.
Thank you.
So I was noticing that it's 49 and 49 for medical and nursing board use, and similar number of clients. But then I was noticing the ask was 250,000 for nursing and 125 for medicine. So I was just curious where that comes from.
Do you want me to speak to that, Mandy? Okay. So initially, when we introduced nurses, the ratio of nurses to physician use of the program was going to be significantly more, because there's significantly more licensed nurses, and that did prove true as we increased utilization. So that's what those that's what that was based on. For many years, we did have nurses utilizing the program at a much higher rate.
And I can speak to that a little bit too. So good to see you, Eden. And I'm not sure if we've met before, but hello, Dr. Hudson, good to meet you. So a little context on that, since some of you know this and some of you may not, but when I was in the legislature during COVID, I led on the bill, House Bill 4003, to include nurses in the Oregon Wellness Program. I had no idea I would ever end up in the executive branch here at OSBN talking about Oregon Wellness Program in a different way. But until 2022, it was physicians. And at that time, the medical board and physicians said, we will cover also paying for APRNs, but nothing else. And so advocated for what at the time, working with the executive director and the board president then, how we were going to come to a number, and it was 500,000 a biennium. So every biennium, $500,000 of licensing fees can be used as to Oregon Wellness Program. And so the way that we've done it is $250 a year. And so, which is why that ask was here. But Eden, correct me if I'm wrong, and again, I'm just going off the top of my head. I thought they actually gave more money than us, and there was some concern, because we have so many more licensees that we're going to need it. And, and that was a concern of the board in the past of how are we going to serve so many nurses in need. And we did see that happen where they had to go from 8 visits to 3 visits. But I don't know if you know off the top of your head, and if not, I can, come back to the board with some numbers, and you all have some of these slides in your public board packet, but then we have some updated ones that we can send. But Eden, do you recall what is the total amount that their licensee sends a biennium?
So it's the OMB is still 125,000 a year.
Okay, so they are half of us, and they are a quarter of licensees than us. So, but it is interesting. It should also mean that more visits can happen if we have more licensees and giving more.
And we're really so when we reduced services, we were very, that was something we needed to do to sustain the program and make us financially sustainable, which we have done. And I think this last year we spent sort of seeing what that would look like and what the demand would be at that point. And I think we've seen across as Dr. Hudson mentioned, that we have maintained the same new client rates that we had prior, but we sort of worked out what it's going to look like moving forward, most likely. And now that we have more breathing room with our budget and we've reduced the number of sessions, we can provide more care to more nurses and doctors. So that's what our focus will be this year, is getting the word out more. It's always a tricky balance when you have a limited budget between marketing, because obviously if every single nurse in the state decided it was time to use the OWP, it would overwhelm our budget. But I think there's definitely room to market more to clients who don't know about the program, because obviously that's, the people you want to know about the program are the people who need the program right now. So.
Well, and in full transparency, the presentation I give Oregon Wellness, Nurse Wellness is Public Protection. I speak to nurses across the state and say, we remove the mental health questions from our applications based on the board decision, the access to Oregon Wellness Program. And overwhelmingly, when I'm in the room, they don't know about it, but they leave knowing about it. And then they also then find out that we're now in the Alternative Discipline Program. And that is, all those three things are because of, you all on this board. So it is interesting to see people say they don't know about it. And it'll be a room of 50 to 100, and be interesting to see if you all start to hear from them giving the presentation on February 28th.
Great. Yeah. And this, the executive committee, one of our 2026, our main 2026 goal, other than hopefully getting legislative funding, is to work on marketing and work on that outreach. Again, like Eden said, now that we kind of feel like we have a better idea of what services are going to look like and what our costs are going to look like with this new model, we do feel like we're at a point where we want to push that outreach.
Board Member Stanich.
Thank you for the presentation. I have three very short questions. You had mentioned 3 sessions. Is that within a calendar year? Is that able to be carried over? That's the first question. Then how long are these sessions? And I'm sure each one is individualized, I would imagine. And then lastly, because nurses and the hours that they work, is there that availability that there's after hours and so forth for the nurses to have these sessions?
Yeah, so the first question, right now it's 3 sessions sort of as a lifetime benefit. So we offer those 3 first sessions, and then people can continue as they see fit. The second question, how long are the sessions? They tend to be 50 minutes. An intake might be a little bit longer, but Eden, correct me if I'm wrong. I think that's up to the individual provider and how they want to run that. And then with the after hours, I think most of our providers, if not all, offer, hours that would work for people who are, working crazy shifts and everything.
Thank you very much. Any other question? So we'll really love to see you back. This was a great presentation. Looks like you're asking more of us, and it sounds like you want to do more marketing also. But the conversation about reducing this free sessions to 3 and seeing how that goes after marketing, since you guys will be able to see where your balance is, to ensure like if we can actually put back up the free sessions with your new budget plan, that would be really helpful to know how that plan is going.
Thank you so much for having us. Really appreciate it.
Absolutely. We look forward to seeing you soon.
Okay, take care.
Thank you.
Bye.
Do we have any other random agendas? Okay. Looks like the meeting is adjourned at 2:03 p.m. and our next meeting